This is an incredible initiative that really started grassroots, and it's amazing to see it grow over the years. And it's my pleasure to join. So I do have slides, so I'll share them in a moment. But certainly, if there's any questions that come up, don't hesitate to just unmute and ask or anything like that. Uh, can keep it very informal, as some of you know, very accessible and reachable. If there's anything that you want to follow up on or any questions you might have, really, I'm available at any time. You can just text or email me or anything like that. Okay, so let me just go ahead and share my slides. Okay, and just confirming that you can see my slides.
Yes,
Awesome.
yes.
Okay, perfect. Okay, great. Thanks, guys. So, again, oops, sorry. You can still see them?
Yeah, it's still here.
Okay, great. Okay. So yeah, it's a pleasure to join. My name is Neil Lipsman. I'm the residency program director at the University of Toronto and have been. I'm now entering my sixth year in doing that. I am a graduate of the program as well. I did medical school at Queen's University, and I currently work at Sunnybrook, which is one of the four training sites at U of T. Tremendously proud to be the PD and also a member of our division and to have been a graduate of our program. So what I hope to do over the next 20 minutes or so is give you an overview of neurosurgery, but also our program and what I think makes it a really unique program. And again, feel free to ask any questions. So really just beginning at the very beginning, I think that many of you are across the different stages of medical school, maybe thinking about neurosurgery or already set on neurosurgery, but essentially, neurosurgery is a group of these 7 subdisciplines. Each one of them is a fellowship training program that really spans all CNS pathology, including brain and spine. In Canada, neurosurgery is a 6-year program. Typically, there are approximately 18 to 20 CaRMS spots every year. We have 4 CaRMS positions for CMG applicants, Canadian medical graduate applicants, in Toronto, and we have usually 1 IMG position. And I'm sure you guys have all heard of the recent changes to the IMG definition of IMG. Certainly, we can discuss that. We have lots of information about that through our postgrad office, but usually 4 CMG, 1 IMG position. Most of our residents do decide to do some research. So they take about 2 to 4 years out from their training to do dedicated research time. And that is often translated into a postgraduate degree. And almost everybody will do a fellowship at the end. And this is really common across all surgical and increasingly medical and pediatric disciplines, doing 1 to 2 year fellowship after the end of training. And these 7 areas are the areas where most people will do their fellowship in. So this is who we are. So last year we celebrated our centenary, actually, 100 years of neurosurgery at the University of Toronto. We're certainly the oldest program in Canada, one of the oldest in the world, really, a dedicated neurosurgical program. We're comprised of 4 training sites: Toronto Western, UHN, St. Michael's, Sunnybrook, which is where I am, and Hospital for Sick Children. We also have 2 community partners, one Trillium Health Partners, and we increasingly work with Kingston General Hospital at Queen's. So Queen's, as you know, does not have their own neurosurgery residency program, but all of the staff there are Toronto trained. So we sometimes send residents there to rotate through neurosurgery. Our program is administered by an RPC led by me, as well as the chair of neurosurgery. Currently, it's Jim Rutka, acting as the interim chair. Each site will have a site director. We have an overview. We have a overall curriculum director, as well as a competence by design lead and 4 resident representatives. And ultimately, all evaluations and assessments are governed by a competence committee that's chaired by Dr. Das currently. So you'll hear me say this very, very often, which is we are incredibly proud of our resident body. We have an outstanding group, and they are the best ambassadors of our program. So if you ever have an opportunity to meet any of them, please do ask them questions, ask them why they came to Toronto, what their experience is like. They are always happy to share that experience, and they are really the engine of our program and what makes it really so good. So typically, neurosurgery residency is 6 years, as I said. Of course, as you know, we are very well ahead in transitioning how we measure and how we evaluate residents across the country. Historically, it's been a time-based curriculum where 6 years are spread over junior research and senior residency. We've now superimposed something called competence-based curriculum. This is now permeating throughout medical schools, but also residency training, where we don't change the number of years of training, but we do change how we define assessment and evaluation during that training. So it means that over those 6 years, you would progress from 4 stages: the transition to discipline and the foundations of discipline, which lasts 2 years, core of the discipline where you learn most neurosurgical skills, and then the last 6 months, which is a transition to practice. So it doesn't really change on a day-to-day basis what residents do, but it certainly changes how we evaluate, how we assess residents, and how we determine that they go on to the next stage of their residency. Another way to look at it is like this, and you'll see this. This is provided by the Royal College. When you finish medical school, you'll enter that first stage, that transition to discipline, where it's basic orientation, and then foundations of discipline, where you really learn broad competencies that apply to every surgical discipline. And then once you pass that, you go into the core of discipline. And that's where you really learn discipline-specific competencies, cranial surgery, spinal surgery, etc. The Royal College exam is done in the 5th year, the written part, and then chief year, and then transition to practice, and ultimately the oral exam. So that's the overall structure of residency. So when I think about U of T neurosurgery, I really think about 3 areas that we're incredibly proud of and that we stand up on. So I refer to these as really the pillars of surgical training at U of T. And I'll go into each of these in a little bit of detail. So the first one is really excellence in clinical training. So we're proud that we have the largest and most clinically diverse training program really in North America. So we currently have the largest volumes, over 6,000 cases per year amongst these 4 sites. And they include the full spectrum of all surgical disciplines. So you'll recall that the first slide where I showed all the different subdisciplines, we're really one of the very few programs in Canada to see high volumes in each of those subdisciplines, including the rarer things like functional epilepsy and peripheral nerve. So we do quite a bit. And the way that you sort of look at that is you look at what the residents are doing, and their chief residents who are in their 5th and 6th years, so the last year of their training, they routinely log well over 600 cases in a 12-month period. So that is certainly ranks them in the top in terms of volume in North America. When you look at typical surgical logs for US training programs, at the end of their training, typical resident in the US will log 1,300 cases over the course of their residency program. So our chief residents do over 50% of that just in their last year. So very, very busy services. So what do each of these sites do? UHN sees the full breadth of neurosurgery, every discipline except level 1 trauma. So that'll be St. Mike's and Sunnybrook. Epilepsy's there, extended skull base, radiosurgery, all of that is happening at UHN. At St. Mike's, it's a level 1 trauma center. There's a lot of expertise in MI, minimally invasive spine and spine trauma, very busy vascular service and skull base oncology. At Sunnybrook, which is IM, we have 2 hybrid and open and endovascular surgeons. We do a lot of minimally invasive surgery like ultrasound, focused ultrasound, skull base expertise. We're Canada's largest and busiest trauma center, and a lot of complex spine. SickKids, really the crown jewel of our program, recently ranked the #1 pediatric hospital on the planet, and the neurosurgery group is no exception there. It's a global leader. Every subdiscipline of pediatric neurosurgery is represented, from the weird and wonderful to the regular. So really, really an incredible place. What about research? We definitely have a reputation for doing a lot of research. We're very proud of that, and that we've set really the standard for academic neurosurgery on a global stage. We have the largest proportion of surgeon scientists and investigators on faculty anywhere in the world, really. So, and there are objective ways you can look at the metrics. You can look at grant capture, publications, as well as membership in the major societies. One of the sources of that is again, it's not neurosurgery specific, but it's U of T specific, and that's the surgeon scientist training program. So what that is a program dedicated to fostering research among trainees. So that 4th year of research, that 4th year of training that all of the residents do research in, if they decide to pursue a degree of some kind, they'll be fully funded throughout the course of their research training. So that is really unique to the University of Toronto. More and more programs across the country are trying to model that, but we're very proud of that. And many of our residents have gone on to get secure funding, external funding from multiple sources, and published in some of the top journals out there. So what does things look like across a 6-year residency? The first 2 years, you'll do core adult and some pediatric neurosurgery, some electives, as well as off-service rotations and things like ICU. In R3, it's mostly neurosurgery with a little bit of stroke neurology in there, but really the dominant theme across the third year is consolidation of basic neurosurgical skills. R4 is research, and R5 and 6, there's neuropathology, and then there's the chief year that begins at the 12-month dedicated, focused, intense year of advanced surgical training. We're in order to guide residents through the research process, we've developed a research council. This is something Dr. Zade, and she was the chair, and I helped spearhead. And this is really to harmonize and coordinate research efforts across the division. So we're 4 sites. So we try to harmonize things as much as possible across the site. So we encourage strong interdisciplinary collaboration between the sites, and whether it's trials or grants or things like that, we really try to foster that. Mentorship was a gap in our program several years ago. It's now been filled by Dr. Ibrahim, who's our mentorship director. So we identify resident mentors and faculty mentors with everybody that matches to our program, even before they start. So we really help them navigate, to understand what their needs are, to help with career counseling, research counseling, things like that. And that program has really flourished under Dr. Ibrahim's leadership. To give you a sense of the kind of research that's happening in our program, these are 3 of our trainees. Newton is actually just finished his spine fellowship training in Calgary and his functional fellowship in Toronto. He's now on staff in BC. He went on to do, during his research, he worked in Geneva with Gregoire Courtine, who's a scientist looking at spinal cord injury and rehabilitation. So he published work in Nature. Justin Wang did his PhD with Dr. Zade, looking at molecular classification of brain tumors and meningioma specifically, published in Nature Medicine. And Laureen, both of them, Justin and Laureen, are currently chief residents. Laureen worked with Micah Feelings and Charles Tatter, publishing work here in stem cell reports, but more recently, as of a couple months ago, in Nature Neuroscience, looking at translational work in excitotoxicity in spinal cord injury and scar generation. So just to give you a flavor of the kind of work that is possible to do at the University of Toronto with some of the mentors, and also if one chooses to go abroad and join a lab elsewhere, we're certainly supportive of that as well. So one of the things we're also very proud of is community engagement. The neurosurgery community, as you'll see, as you go through the process, is not a huge community. It's really tightly knit, especially in Canada. But we're proud that many of our faculty are really on the front lines of engaging in conversations that are happening on the global stage. So if there's something that you're interested in neurosurgery, whether it's global surgery, whether it's ethics, setting standards, maybe more controversial things like psychiatric neurosurgery, or if you're focused on well-being, et cetera, somebody in the city is doing that, or knows somebody that's doing that. So if you want to get involved and plugged into things like education and advocacy, we can help there because somebody's involved in that. And we've managed to have an impact on the global world of neurosurgery. So we're very proud of that. This is where I'm going to put modesty aside and really, showcase some of the global leaders in our program. And Dr. Zade, who was our chair, and is currently the chair of the Mayo Clinic as of last year. We have neurosurgery, Gardner Award winner, Dr. Lozano, who's a global leader in functional neurosurgery, and Dr. Rutka, Tatter, Drake. These are all individuals, and Dr. Failings, who are really world leaders in the area and have transcended the field really, and have become authorities and pioneers in the areas, and they're available, accessible, and really outstanding mentors. But as I mentioned very early on in the presentation, it's our residents that are really the driving force of our program. We have 32 residents right now, about 60% are doing clinical work, 40% research, and they really represent the full breadth of backgrounds in Canada. So every undergraduate degree has been represented, background, med school, province. We absolutely do not favor or discriminate against anybody from any school from across the country. We are really consider ourselves one of Canada's, a Canadian program, that's Canada's program that trains people from across the country and really from around the world. And in terms of our city, again, putting modesty aside, we really feel we're the diversity, culture, sports, and food capital of Canada. So if there's something that you're interested in from a cultural perspective, look no further than Toronto. So we're very, very lucky to live in this highly heterogeneous, multicultural city that's really the one of the most livable places on the planet. And of course, I'd be remiss not to mention World Series champions in a few days. I'm sure you guys are aware of that. So, and our residents are the engine. So again, I've said this before, but I'll just reinforce: if you have a chance, reach out, speak to them. They're very accessible, very approachable, and will tell you the ins and outs of our program and everything that it has to offer. I mentioned this a little bit, that we really consider ourselves kind of the world's training program. So because and by virtue of our position in neurosurgery, in the world of neurosurgery, we managed to attract a lot of international applicants to especially our fellowship programs at some of the more sort of high impact areas like pediatric neurosurgery, spine, oncology, and functional. And it's very heartening to go to a meeting, a national or an international neurosurgery meeting, and you meet individuals who have been trained in Toronto. So you really are part of a global community of people who have trained at the University of Toronto, and you share that from around the world. One question that often comes up across the board is, will I have a job at the end of training? So the answer to that is a loud yes, you will, and it will be a good job. Approximately, I would say 50% of our graduates stay in Canada, but 50% go to the United States usually. That's, by the way, similar to other surgical training programs, not only neurosurgery. And we've seen this is an example of where our recent graduates have gone and found jobs. So you'll see that it's everywhere in Canada, but also when they do go to the US, it's really the top tier programs in the US. So everywhere from the Ivy League to both coasts to some of the leading neurosurgical programs such as U Miami and Penn across North America and the world. We've doubled down on our interest in wellness, equity, diversity, and inclusion. We've appointed Abaya Kulkarni, the program director, immediately prior to me, as the vice chair of EDI and wellness. And we've gone a long way to harmonize and coordinating efforts across the division to advance these initiatives. All of our trainees and faculty undergo anti-bias and allyship training, not only as part of resident selection, but as part of sort of day-to-day practice. And it's as a testament to how important it is. It's really become a critical pillar of our strategic plan, which I anticipate will only continue to grow. So I talked about the three pillars, but there is one pillar that I'm very proud of. And, as somebody who considers myself a kind of student of medical history and neurosurgical history in particular, I'm very proud of the role that University of Toronto has played in the history of our field and how central it has been. If you look at the very beginnings of our field, and this is, Harvey Cushing right in the middle there, and to his right, left of the screen, is K.G. Mackenzie, who was one of his first residents. K.G. Mackenzie went on to be the first chair of neurosurgery in 1924 at Toronto General Hospital, really founding a dedicated neurosurgical unit. So we can trace our lineage all the way to the father of neurosurgery themselves. After Mackenzie was Harry Bodrell. He was the next chair. He was instrumental to treating spinal cord injury and pioneering how we treat and rehabilitate individuals who've undergone spinal cord injury. One of the first neurosurgeons even interested in the spine. And he went on to become the dean of the medical school at Queen's, and the medical school building, Bodrell Hall, is named after him. Thomas Morley, British trained with Geoffrey Jefferson, Sir Geoffrey Jefferson in the UK, a pioneering functional neurosurgeon. And he was a chair for several years. He was followed by Alan Hudson. Alan Hudson took the program in an entirely different direction in the 70s and 80s. And once he finished as chair, he went on to leadership in the administration world, became the CEO of Toronto Western Hospital, and ultimately merged Toronto Western with Toronto General, making the University Health Network. So even beyond neurosurgery, having an impact there in the world of medicine. Charles Tatter is a pioneering figure in the area of head injury, still practicing into his 90s at Toronto Western. And as I mentioned, supervising our students, including Laureen Hatcham, and really a member of the Canadian Medical Hall of Fame, a very influential figure. His chairmanship was followed by Jim Rutka, who also went on to become the chair of surgery at the University of Toronto and the president of the American Association of Neurological Surgeons, and is currently serving as an interim chair. Andres Lozano as well. So I did my PhD with Dr. Lozano But Lozano has the distinction of being the most cited person in the field of Parkinson's disease. So not neurologist or surgeon, but person. So there is nobody in the world that that has made as impactful a contribution to Parkinson's disease and surgery for that disease as Andras. So really a pioneering figure in neuromodulation. Gallery Zade was a chair that worked together with me on the program as program director. She really is a consummate scientist, consummate outstanding master surgeon who ultimately left UFT to become the chair at the Mayo Clinic. So just to give you a sense of, the kinds of places that people can go after they've trained or worked here. And what I encourage you to do is looking at this list and looking at these individuals who really think of yourself as part of that tradition, part of that history, part of that legacy of neurosurgery, and really to think about where you see yourself fitting into this. And hopefully you see yourself as part of that lineage. So with that, I'll introduce you to the RPC. So each site, as I mentioned, has a site director, Paul Conkham at UHN, Sarah Ali at St. Mike's, and Suna Das is our CBD lead. Ashish Kumar is a site director at Sunnybrook, and I serve as the PD. George Ibrahim is a site director at SICK. Is Jim Rutka. Sorry, his photo's not here, but you saw him before. He's the interim chair. And we have 4 outstanding resident reps who I do hope you have a chance to meet. And they're Sydney, who's in PGY 3, Jessica, PGY 4, Patrick, PGY 4, and Chloe, also PGY 4, doing her PhD in Dr. Zade's lab. There he is. Okay, okay. And that's it. I mean, this is how you can get in touch. So, we're on I believe we're on Instagram. We have an X account. Here's my email address, and the email address of our interim program administrator can give you all the information you need about our program and next steps and things like that. I know that CaRMS is coming up. I know that the applications are due, I think, at the end of November. And then the process then begins in terms of interviews and application reviews, et cetera. And I'm happy to answer any questions related to that. So with that, I'll end there and have a few minutes for questions, if you have any.
Thank you so much, Dr. Lipsman. So the floor is open for questions. You can chime in, raise your hands, or just unmute your mic and ask your questions. You can also use the chat.
I answered all the questions in the presentation.
I would love to ask a question if that's okay.
Yeah, of course.
So you're talking about the multiple different training sites, and I was just wondering, with the multitude of residents and the different neurosurgeons, how you ensure that the residents moving through all those different training sites, that staff, when they work with them, have an idea where they are on their training perspective and modifying training to be individual for residents among so many people.
Yeah, that's a great question. We often get the comment of, you're such a big program. I'm going to get lost in the program. And, there's 30 plus residents, 4 training sites, big city, et cetera. But I encourage, students not to think of it that way. I encourage them to think of the fact that, yes, there's a lot of us in absolute number, but each training site is almost like a distinct residency program. So if you were to take each training site and put it in another program, it'll be like the whole residency program. And each site has its own distinct culture, its own distinct staff, and its own distinct flow and things like that. So it becomes really a community at that site. So for example, at Sunnybrook at St. Mike's, there's usually no more than 4 or 5 residents at that time across the spectrum of the years. There's a chief resident, and there's going to be a PGY 1, 2, or a PGY 3. And it just takes a few days for the staff to realize, the different levels of training and how to work as a team. At all the sites, there's usually buddy call, at least for the first time. So junior residents is going to be on with a senior resident or a chief resident, usually at all times. Sunnybrook, there's not often a chief resident. So sometimes the residents are on solo with the staff, which they like and which we encourage for sure, because it's an opportunity to work one-on-one with the staff. But you can very quickly learn that, it seems like a big program, but in fact, when you're at the site, you sometimes wish that there were more residents around because there's so much happening, there's so much doing. So I think that, it's a great question, but we try to keep it really tightly knit. And the people that are on service really have usually quite a positive experience.
Sounds good. Thank you so much.
No problem.
Thank you.
Alright.
We have a question in the chat from Raphael. What opportunities do you have for medical education?
Yeah, tons for sure. You can look at a medical education. I'm assuming to learn about, to like do research and things like that in medical education is what you mean. Especially with the rollout of CBD, we're just learning. We're in the 6th year, but we're still adapting, still learning how to integrate that into the program. The result of CBD is tons of data, tons of what we call EPAs, tons of assessments, tons of competencies that need to ultimately be completed. And nobody's really looking at that. So there's tons of opportunities to sort of map competency acquisition with EPAs and to work with individuals in our division who are really interested in medical education. So Ashish Kumar, one of my partners at Sunnybrook, is really interested, for example, in endovascular and how we can integrate endovascular skills, endovascular experiences into general neurosurgical training. So what competencies does a junior resident need to have, for example, for angiography? What does a senior resident need to have? So those are really just at the germinal stages. So I think that if one is interested in medical education, it's a great opportunity. And now is the time to really look at that.
Hi, Dr. Lipsman. Thank you so much for the talk. My name is Brooke. I'm from Calgary.
Yeah.
My main question is for students who already have like higher grad degrees, like PhDs, what
Yeah.
does the research support in terms of like doing postdocs look like? And do they get extra time on top of that 1 year, or what does that look like?
Very, very apropos, because I was just speaking to one of our residents, Sydney McQueen, actually, who is a PGY3. She has a PhD. She did an MD PhD in actually surgical education, as it happens, and is interested in doing something for a 4th year. So, and we have somebody, Patrick Stedman, who's on RPC, who's now doing a postdoc in California, in Stanford, actually. So he's interested in cancer neuroscience. So he worked with. He did basic translational work during his PhD, and now he's doing a postdoc 2 years at Stanford. So in short, lots of opportunities, and we can get as creative as you want. So I've really tried as much as possible to foster creativity amongst the residents and to allow that as much as possible. So if you're already coming in with a PhD and you want to do a postdoc in that 4th year, I often say, think about doing it for 2 years. Think about having maybe some clinical experience in there. Either do it locally or do it wherever you want, but you can do it locally or elsewhere. But a year goes by, for example, very, very quickly. And when you come back for your 5th year, you're going to be writing your Royal College exam. So you want to build in some studying time there as well. So those kinds of nuances are very, very important. And also funding will be important as well. But I think that that's where SSTP does support postdocs. So that's actually quite unique as well. So certainly lots of opportunities.
Okay, great. And just to kind of follow up on that, so for a 1-year program, I totally understand how that would be kind of covered by that and funding and everything. But for that 2nd year, after you've done that kind of structured year, what does do you have to acquire your own funding? Is it funded through other things?
Yeah, so the 4th year, the 1 year is completely ministry funded. The 2nd year, for sure, we would need to find funding for that, and that's where we would go to SSTP and say, we would want a continued support. They have been successful in doing that. We would also apply for grants early. So Patrick, for example, applied very early on and was able to get some grant support to get some salary support. So we would not let you not be paid for that year. So we would find a way to make it happen, usually applying early for grant support through either SSTP as a backup, as sort of a cushion, or we'd work together with SSTP or the Department of Surgery to support you.
Okay, awesome. Thank you so much.
No problem.
Thank you for the questions. Are there any other questions? Great. Well, thank you, Dr. Lipsman. This was a very wonderful presentation. And sorry about that. We appreciate the conversation.
My pleasure.
If there are no other remarks, we're ready to move on to our next.
Okay, amazing. So I'll just say bye, and please reach out. Don't hesitate to email me any questions you might have. And I wish you luck in your journeys. And don't be a stranger. Reach out to me or the residents. Always happy to hop on a Zoom or phone call to chat. Thanks very much, guys. Enjoy the evening.
Always great to have you.
Thank you,
Take care.
Dr. Lipsman. All right. Next up, we have Dr. Yarascavitch joining us from McMaster, another familiar face. Thank you so much for joining us today, Dr. Yarascavitch. The floor is yours. I'm just going to make sure that you're able to Negin. Can you make sure that?
Yeah, I have sent a request for screen sharing.
Yes. If you can just make him co-host too.
All right.
Perfect.
Awesome. All right. Well, thank you. Thank you for the invitation. Big thank you to you guys here at CaMSIGN just for hosting this event. I know it's a popular event. It's super helpful, I think, to get an overview of the different programs kind of all at once. Especially, I think, early on. I mean, I know several of you guys are kind of in this CaRMS cycle and applying and getting ready for transition to residency, but also I know there are people who are just starting with interest in neurosurgery, and so it's really nice to get early exposure and get to learn a little bit more about to see if this is kind of up your alley. So I'm going to talk a little bit today just about the introduction of us at McMaster, talk a little bit about program design, some of our educational opportunities, and then try and leave the floor open for questions for you guys, okay? Firstly, right now, I'll just tell you a little bit about our staff for people who have not been able to come and see us in Hamilton. We have 13 faculty members with practices that vary across the spectrum of neurosurgery. So spine, vascular, endovascular, skull-based oncology, critical care, and pediatric neurosurgery. And typically we have anywhere from 2 to 3 residents per year, and our current intake cycle is 3 years, 3 residents per year, 2 from the CaRMS pool and 1 as a visa trainee. This is most of our adult faculty, and so up there on your panel on Dr. left, Dr. Alex Senek. He is actually a McMaster graduate, having done his residency program here, and is one of our spine surgeons. Below him, Dr. Guha is also one of our spine surgeons. He joined us about 5 years ago now. Dr. Van Adel is actually a neurologist, but he is embedded into our academic activity as he is his practice is entirely endovascular. So he participates in the neurosurgery program both functionally and academically. Dr. Wong next to him is also a vascular and endovascular neurosurgeon. Dr. Ajir is one of our skull-based surgeons. Dr. Kishore is one of our vascular and endovascular surgeons, as well as a generalist. Dr. Reddy, who's our senior staff here, is a skull-based neurosurgeon as well, and has been running a fellowship for a number of years. And then Dr. Sharma is he's part-time neurosurgeon, part-time critical care. He's combined neurosurgeon and intensivist, and helps run the step-down unit. On the next page here, Dr. Omar, he's our surgical oncologist, and Dr. Karapetian is our most recent recruit. He actually started just at the beginning of September, and he's our newest spine neurosurgeon. And then along the bottom there is myself, Dr. Singh, and Dr. Arjani. We're the 3 pediatric neurosurgeons over at the Children's Hospital. Myself as program director, Dr. Singh is the academic division head. And then in addition to our normal clinical faculty, we have several spine fellows shared between the orthopedics and neurosurgery program, anywhere from 1 to 4 spine fellows per year. 1 to 2 INR fellows per year, usually 1 skull-based fellow per year, 1 pediatric fellow per year. And we are currently recruiting for a replacement pediatric neurosurgeon. Dr. Singh is transitioning to full-time research and stopping clinical work within the next year, and so we'll be looking to replace her. On the resident side, these are our PGY1s and PGY2s, Sophie, Amro, and Khalid, who have all just started their residency not too long ago and then settled in quite well. Zara, Dana, and Rufus are our PGY2s. And then in our senior cohort, we've got Anyani, Rami, and Nadine, who are PGY 3 and 4. And then we've got a couple of residents who are currently in the CIP program who are forever PGY 4s, at least for a little while. Shannon is completing her second year of her master's program this year and will return to service. Next year in July, Dr. Kesawan is finishing up his PhD this year. He's been gone for 3 years and will be returning with a PhD in July. And then Dr. Kabani is our PGY 5, and Dr. Lannon is our PGY 6. As you guys know, have heard, it's a 6-year program and a competency by design model. Dr. Lipsman was just talking a little bit about that, completing EPAs and entrustable professional activities to demonstrate your competence across different domains. And that is the same across all the neurosurgery programs in the country. The first couple of years are also surgical foundation years, where you get to expose to all surgical disciplines and get you ready for a surgical foundations exam that is in your second year. And that is also a competency by design model as well. Typically, this is what 6 years looks like. The first year, we have you on neurosurgery a little over half the time, but also doing some off-service electives, getting some general surgical exposure, doing things like ENT, plastics, radiology, emergency medicine as well. All things to kind of help broaden your horizons and get you used to how things work in different areas of the hospital. As a PGY 2, about again half neurosurgery, the other half a combination of things like ICU, neurology, and often vascular surgery or some other surgical subspecialty. PGY 3 is kind of like a core senior junior year where you've established your foundation and really are working to work on your surgical skills. And typically that is all neurosurgery split between adult neurosurgery and then about 3 blocks of pediatric neurosurgery. PGY 4, this is taken many different ways. Some people choose to do CIP or master's programs during their PGY 4 year. Also, we've done electives or other research activities, as well as just core staying through in neurosurgery. PGY 5 and 6 are also kind of mixed mixed together. About half of PGY 5 and half of PGY 6 are often chief years, kind of the end of PGY 5, the beginning of PGY 6. As though that we have staggered it over the last little while because of how the exam has changed to being the written part at the beginning of the 5th year and the final oral part at the end of 6th year. Also, we could do things like we'll have a senior pediatric neurosurgery rotation, other electives, neuropathology, neuroradiology, and other community electives as people are interested in. Throughout the program, we have a lot of different educational activities. Friday mornings is that kind of academic half day, kind of brain school type stuff where we start out the day with case rounds in the morning and then have our combined neuroscience grand rounds along with all the other adjunct specialties like neurology, neuroradiology, neuropathology. We also have didactic and practical things. Again, cover our curriculum over the 6 years. We get through the curriculum about twice, so you get exposure to kind of both basic science topics and didactic lectures throughout your residency program. We also have gross pathology, anatomy labs. About maybe a quarter of our academic half days involve the anatomy lab and doing approaches. We also have things like monthly M&Ms, journal clubs, and weekly rounds in spine, vascular oncology, and pediatric neuro-oncology that the residents participate in. We have written and practice exams and oral exams, neuroscience research day, often other courses that our faculty runs here, such as pituitary education day. We have a skull-based that Dr. Reddy and Dr. Summer run from ENT, and a minimum invasive spine course that's run by, again, Dr. Reddy and some of the spine surgeons. We've got divisional research rounds, senior case rounds for exam prep, This is just some examples of some of the things that we have done. This is kind of a bone handling and drilling course that we did during our academic half day to get everybody set up and ready. Also, we get to do things like practice endoscopy and ventriculostomies. This was Dana making some nice patterns on an egg, just practicing kind of the fine technique of using the drill. And then on the other side of things, we also have retreats, and this is our spring retreat. We spent doing some horseback riding, developing other skills, and talking about challenges and opportunities within the program. For the clinical side of things, there's 2 adult clinical teams at the Hamilton General Hospital, which are divided, where we kind of divide the work. So although we are kind of at one center there on the adult side, the patients are roughly divided into half based upon the MRPs and their specialties. And so you rotate through each team and get exposure often to individual things, but you also get to see everything when you're on call. And then we have a separate team over for peds at the pediatric hospital. On average, we do around 2,000 to 2,200 operative cases per year, anywhere from 200 and 250 on the pediatric side. Just my outgoing chief residents, they finished about 2,100 cases over the residency, and those were all ones who did about research during a research year. Those historically, we've had a couple that haven't done research year, and that gets up to around 2,400 cases during residency, give or take, and not considering all small procedures or repeat procedures sometimes for patients. From the research side, we've got a couple of formalized research groups. On the pediatric side, we've got the Pediatric Brain Tumor Study Group, which is comprised of both us as the pediatric neurosurgeon and the neuro-oncologist, as well as our radiation oncologists and neuropsychologists. And we operate kind of a database of our brain tumor patients and use that as a study material. And then the adult side, Dr. Sharma runs a cranial research group, which is critical care, neurosurgery critical care interest group as well, where he supervises multiple students and projects. We have an excellent research assistants who help us get things going and keep them moving, specifically things like REB and protocols and all that kind of stuff. Amanda Martinick is our fantastic primary research assistant with a couple other research assistants who help out. And that group typically publishes anywhere from 40 to 60 articles over on a yearly basis through the various different both basic sciences, clinical case reports, etc. As I mentioned, we have 2 CaRMS positions and 1 visa trainee per year, and we average around 2-3 residents per year across our residency program. Our hospital system in Hamilton has 2 major hospital systems, Hamilton Health Sciences and St. Joseph's Hospital system, and the majority is within the Hamilton Health Sciences aspect of the majority of the work is done between the 2 hospitals, the Children's Hospitals and the Hamilton General Hospital, although residents do rotate through and see some other sites. The Hamilton region we cover, although we are here in Hamilton, we cover all of the Niagara Peninsula, and then about halfway out towards London, and again about halfway towards Toronto, depending upon what the service is. So get dividing up where there are other smaller segments, but for example, pediatrics, we cover this, and then again out north of Waterloo, Wellington areas as well. And we overall have a catchment of about 2.5 million people that we serve as the primary neurosurgical center. This is Hamilton, the city. As you can see here, it's at the end of Lake Ontario. You can see this out looking over the harbor, over the old industrial part of the city, with Toronto in the background, so not too far away. But this is what the rest of the city mainly looks like between the escarpment and the rest of the city down below the escarpment. A pretty vibrant city. Lots going on here. It's a nice downtown area that's just been gentrified a whole lot over the past 10 to 15 years, with a lot of new development, a lot of opportunities and culture that a lot of the residents get to enjoy and spend during their residency. for something completely different for a couple of minutes. I know I like to put in random things here about neurosurgery as a career, not just to talk about our program, because again, sometimes this is what the questions are about. This is just a couple of recent studies. I've talked before about kind of job prospects and underemployment in Canada. These are a couple of recent papers. This one's looking at worldwide, looking at perceived barriers to neurosurgery as a career for medical students, looking at the literature. And there were a few themes. They had about anywhere from 40 to 60 papers, depending upon what theme they were looking at. But some came up specifically, which probably resonate with a lot of the group here. Gender-related barriers, stereotypes, and global lack of female mentorship within the actual specialty. Work-life balance and challenges of work-life balance, things like tedious, long working hours required of a neurosurgical career were shared amongst many, and it was mostly on how that impacted family life. The academic rigor of the career, both in terms of applications, competitiveness to be able to get into it and get through and pass the final exam. More than half of students expressed that in some of these studies. Financial costs, depending on where you are in the world, the barrier to entry can be quite high because of standardized examinations and other things which might, and the long duration of the residency program as well in terms of indebtedness. This is another paper from this year looking at the work-life imbalance and what they kind of put as a challenge and an opportunity for neurosurgery, and what is always some of the themes again that came out is that there is a work-life imbalance. This is a survey of about 650 or between 600 and 700 neurosurgeons internationally, both in high and low-income countries, that looked at what the work-life balance was, and it was pretty 50-50. So if you're a staff, about 50% said they had a good work-life balance, but 50% said they didn't. If you look at trainees, it was closer to about 75% said they didn't have a good work-life balance, and about 25% said they had a reasonable work-life balance. But there are definitely challenges within neurosurgery around these areas, and so it's something that we can talk about. I'm on the side that thinks I have a good work-life balance, despite being on call for about 30 or 40% of the year. I still have time and opportunity to be with my family and do other things. McMaster is a program, some of the strengths just to comment on, we're a small center with a pretty high volume, concentrated in one center, which covers both level 1 trauma for adults and pediatrics with a large neuro step down and neuro ICU. We've got a high volume for the residents, and a lot of residents do a lot of cases and have early exposure. We have excellent research support, excellent PGME support, excellent PA and NP level support, both for the clinical teams. The one thing we don't have, and I'm always honest about, is that we don't have a functional neurosurgeon at the moment, and we're looking to expand that over the next several years. It's been the recruitment itself has been delayed with trying to replace our spine surgeon and other things over the years, but once we get back into the expansion, that's my push, is where we'll hopefully be moving. But we work hard, and the residents work hard during their training for sure. We've only got a few minutes left, and I want to get to questions. I can talk all day about how I like neurosurgery, how I love my job, and what I get to do for patients. But I hope that everyone here shares that. We'll be doing virtual CaRMS as everybody else is this year. If any of you are Quebec, I'm very sorry for your elective experience over the last couple of months. There have been modifications, as you guys may or may not know, for Quebec students, not requiring as many elective letters and not needing them to be specialty specific as well, given the challenges for electives that have happened more recently. And then just again, my contact information, our program assistant contact information, if you guys have questions, if you guys want to meet up and chat, phone, Zoom, whatever, certainly give me a shout, and I'd be happy to do my best to make that happen. And then also, if you're interested, to come to one of our Friday morning half days and see if it's something that we are doing virtual and not in person, we'd be happy to have you along to observe if you'd like. So just drop us a line and we can send you the information. And I'll pause for the questions. I've shown different alpha on the shelf things here before. This was from a recent, a couple months ago, I had a patient who I was doing a cranial vault reconstruction for, and I 3D printed their skull beforehand, and they brought their alpha on a shelf into the operating room to accompany them. So this is the tobogganing in a cranial defect of the alpha on the shelf. I'll bring my PowerPoint down there, and we have a few minutes for questions. So please let me know your thoughts, whether it's about those papers, about career in neurosurgery, life in neurosurgery, McMaster, etc.
Great. Thank you so much, Dr. Yarascavitch.
You're
We're
welcome.
ready for questions. So feel free to open your mics, just open your cameras, or just put your question in the chat and we'll read it out loud. Any questions?
I could ask a question.
Yep, go.
So what's the patient census like in terms of like number admitted at a time and like what rounding is structured like in the mornings as far as who the team is, PAs, residents, that sort of thing?
For sure. So typically on the adult side, on the ped side, it's a little bit different. We'll talk about the adult side where you spend most of your life as a neurosurgery resident. Census is anywhere from 25 to 40 patients on each team, depending upon what what the load is like at the time. We do our best to kind of divvy them out so they're pretty even between the teams. I actually recently restructured the team so that there was a little less imbalance with the changes in staffing that we had. And so typically rounding starts usually handover starts around anywhere from 6:15 to 6:30. And then they do handover and then start rounding around 6:45, 7 o'clock to see the patients get through them. Typically, there's a senior on each team. Teams are composed of usually 3 to 4 residents on each team, typically with a senior resident or a chief resident. And so they'll usually start with ICU rounds and then do ward rounds afterwards. Included that census are also often ICU patients and chronic patients as well. Though we do our best to repatriate patients, we do end up with chronic patients every once in a while. And then usually they do, each team does full team rounds once a week. And so the full team usually rounds with the staff and or the charge nurse. Usually they round with the charge nurse most days when they're going through, but usually they'll round with faculty once a week as well.
Thanks.
No problem.
Any other questions? Guess I could ask a question.
Yeah.
So I just want to know, like, in terms of kind of practicing in the Hamilton area, like, do you find anything unique about like kind of the patient population or the volume that you see on neurosurgery kind of serving the Hamilton area?
Yeah, I mean it's challenging because this is true across a lot of the country. Is that many of the times our patients are an hour to 2 hours away, just geographically. Sometimes in other parts of the country it's a lot more than that. They're looking at 3 or 4 or 5 hours away. So that can be a challenge, just having a large geographically diverse population base that you're treating. With issues around transportation, etc. I think that part of what I've seen change over the last 5 years is that we have a much larger non-English speaking population and immigration that has, we've seen a lot more challenging cases, at least especially on the pediatric side, where we're seeing a lot more congenital cases, a lot more challenging cases around both genetics and congenital malformations associated with either being born elsewhere and coming here shortly thereafter, or coming here with little prenatal care. So it's interesting because with a large growing population in the area, and in fact some of the areas like the Waterloo region is actually in Guelph regions have had really large population increases in the past 5 years, where we've seen sometimes a struggle to keep up with some of the care that's required. But you know, it's interesting. If you look at our hospital system, it definitely is a little bit strained, and so we typically operate, you know, over census at many of our hospitals. I don't think that's unique across a lot of Southern Ontario at the very least. And so there certainly are challenges with getting people kind of through the system, getting them treated and getting them on to where they need to be or to the next stage in whatever their treatment might be.
Great, thank you for that thoughtful response. Any other questions?
I guess I'll just go for a question as well. Sorry. What is the call structure like in Hamilton? Is it more like for example, I'm more interested in like junior residency call.
Yeah.
Are you paired with a senior who's who's at the hospital, or is it at home, or
Yeah. So that's a great question. So we do in-house call for the junior resident. So when there's more than one resident on, the junior resident is in-house. So there's always one resident in-house. Typically, because it's in-house call, we do 1 in 4 call by PRO guidelines. Often actually a little bit less than that, depending upon how many people are on service. And then the junior residents are always paired with the senior until they're ready to graduate, kind of on independence. And so from that, we track a few metrics, and we see you guys in the CaMSIGN committee and talk about kind of fitness for independence. That includes having done enough things like twist drill, craniostomies, and EVDs. We have a what do we call it? A procedure room up on the ward, where the residents are primarily responsible for doing EVDs and subdural drains, and that's done over the overnight and during the day, usually independently. And so we always have a senior resident who's there to teach and help them out. And as they gain independence in those activities and comfort with being first on call, then they usually graduate. So most by usually the depends upon how many months they've done, and in the first year it's kind of 3 months early on. So we typically have all the juniors start on service for the first 3 months. Some of them stay on service, some of them go off service and then come back to neurosurgery later in the year. And so depending upon how many months, usually after about 6 months, you graduate to independence. So 6 months, 6 blocks of adult neurosurgery, we graduate you to independent call. And then there's still the chief most of the time available for issues, and obviously the staff as well. But we tend to make sure you're ready before we leave you on your own.
Perfect. So I guess that would mean that PGY 5s and 6s are no longer required to do in-house.
Yeah, usually, exactly. So most of the time when you're PGY 4, 5, 6, you're usually backup call, or if you're and every once in a while kind of primary care call, but based upon our numbers, it's usually backup call for most of those things. Yeah.
Awesome. Thank you for that response.
Great. Thank you so much, Dr. Yarascavitch. Thank you for the very thorough presentation and for the thoughtful Q&A. I think we're ready to move on to our next presentation. Great. So if there are any other remarks, we really appreciate you attending the event.
Thanks for having me, and please reach out if you have any other questions.
Awesome. Thank you so much.
Take care. Nice to see you with it.
All right. So we have the pleasure of having Dr. Pickett among us again. Dr. Pickett has already given a keynote and has participated consistently in all of our CaRMS night events. It's a great pleasure to have you with us again, Dr. Pickett. With that being said, the floor is yours. You can go ahead if you want to share your screen.
Okay, thank you so much. And yes, I have aimed for consistency. I think bailed on you last year by accident because my flight was delayed and I was actually on an airplane at the time, and it was suboptimal. But thank you so much for having me back despite that. So yeah, you seeing my slides okay there? Yeah.
Yeah, it looks
Um, so anyone who is to our Dalhousie Zooms, some of this will be familiar, but basically that was a chance. I want to give a quick overview and let you get on to talking to the residents, and obviously want to give an overview of the program again. Some of this will be familiar if you did join those, and just be available for questions to me and about the program. I guess just also thank you so much to CaMSIGN for organizing this. And I think I would say that, you know, you can't go wrong really with any training program in Canada. I think they will all give you very good, you know, grounding in neurosurgery and training for independent practice. And so it really comes down a lot to sort of the fit, perhaps the mesh of the program with you, the location, and so forth. So yes, I'm the program director for Dalhousie in Halifax, or Chibuktuk in the territory of the Mi'kmaq. And neurosurgery at Dalhousie, we are a sort of small to medium, we're a medium-sized program. We have 10 surgeons. I put 10.5 in brackets there. So one of our surgeons is transitioning through the sort of tip-top program where transition into practice, out of practice. So we actually, Dr. Simon Walling is winding down his practice over the next couple of years, and we're utterly thrilled to have Dr. Julia Raddick come back home. I like to think she's not from the Maritimes originally, but she trained with us, and she's been working in Saskatchewan for some years, and has now moved back to the Maritimes, and she's basically taking over that practice. So for now, we kind of have 11, although Dr. Walling is winding down. But we're basically a 1-to-1 ratio. We have one CaRMS Canadian position per year. We take occasionally a visa trainee. So we, at the moment, have 10 residents, and we're usually about that 1-to-1 ratio. In terms of the training sites, the majority is in Halifax, where there is the adult site and a pediatric site. We do have community neurosurgery in the Maritimes in St. John, New Brunswick, Moncton, New Brunswick, and St. John's, Newfoundland. And our residents typically do some time, usually in St. John, New Brunswick, where there's the Dal Med New Brunswick affiliated campus, but there's the option to go elsewhere, which I think is a valuable experience. The residents always come back feeling it's been a super chance to kind of solidify their operative skills, and also just, I think, a chance to see a practice, you know, different than your standard academic residency training program. So just giving them a bit more perspective on what a neurosurgical career can be. At the moment, we have a spine fellow. We actually have 2, but they split their time between neuro and ortho. So at any given time, we have 1. And we usually have a functional neurosurgery fellow. At the moment, that's empty. They're coming in January. We also have a nurse practitioner, a clinical associate. We have 6 research and program coordinators, and other research assistants, and a brain tumor nurse navigator. In terms of clinical activity, I mean, the breakdown, I think, is, again, probably fairly similar. We've got, to most places, we got a lot of spine. We've got some cerebrovascular, functional, pediatric, you know, a good chunk of cranial. We are relatively weak at the moment in peripheral nerve. Unfortunately, our fellowship trained spinal and peripheral nerve surgeon left about a year ago, and at the moment there's a extremely good peripheral nerve plastic surgeon who is very welcoming, and our residents are welcome in their clinic, and that's where generally they've been getting the PAs. I do, and as does one of my colleagues, we do some basic, you know, carpal tunnel ulnar decompressions, but the complex peripheral nerve is mainly plastics is carrying that load at the moment. We did about 1,400 cases last year and had close to 8,000 clinic visits. I think we, you know, it's a reasonably busy practice for again a center of our size. Through this presentation, I've scattered occasional slides of Halifax to try and entice you not just to Dal, but to the location. So this is the public gardens. It's like a Victorian laid out gardens. It is literally kitty corner from the hospital. It's, you know, if you have 30 minutes on your lunch break to go walk around it or have lunch in it. It's really nice to just be able to get out of the hospital and decompress a bit. And there's a place that sells ice cream as well, which the residents sometimes go for. In terms of spine, we have 4 fellowship-trained spine surgeons, 2 of whom do functional work, so like spinal cord stimulation and so on, and really the full range of trauma, deformity, MIS, and interacting closely with the orthopedic service, with rehab and so on. So there are designated spine beds on our unit, and we have monthly spine rounds, had them today, discussing complex cases and so on. For cerebrovascular, that is one of my areas of subspecialty. So myself and my colleague, Adrienne Weeks, we are the dual trained cerebrovascular neurosurgeons with endovascular training. And so we do both open cases and working in this like really quite large and relatively new endovascular suite. We have a very good relationship with our interventional radiology colleagues. So weekly neurovascular multidisciplinary rounds and basically neurosurgery and radiology presence at kind of all the interventional cases. And a solid research component there as well that has seen us involved in multi-center, international clinical trials like Sahara, like ECSD2, so publications in New England Journal and the Lancet. So it's a nice, solid research group and cooperative as well with stroke neurology. I mentioned Dr. Weeks, so her other hat is that she is also one of our tumor surgeons. That's her giving a TEDx talk at Dalhousie a few years back. She runs a lab focused on tumor biology, glioblastoma research. We've had one of our graduating residents last year had done a master's in her lab, looking at basically vesicles in glioblastoma and some signaling molecules. And so that's her other territory. And we have the Atlantic Biobank and a number of research opportunities through that as well. In terms of epilepsy, again, I think a theme that I'm going to brag about Dal for is generally its collegiality. I think we do have a very collegial group, and we have great relationships with the affiliated departments and divisions. And so for epilepsy, we have an expanded inpatient monitoring unit, really good interactions with support from neurology, neuropsych, interventional neuroradiology for Almatol testing and so forth, and both adult and child epilepsy surgery. I'll talk a little bit later about some of the monitoring electrodes and so on, but use of the robot for that. Functional, we are the main center in Atlantic Canada for really anything to do with deep brain stimulation, selective lesioning, and also for things like trigeminal neuralgia, hemifacial spasm, glossopharyngeal neuralgia. Pediatrics, so we have generally 2, at the moment 3, again, due to that transition. This is Dr. McNeely on the left there with the photo that went viral a few years back of him suturing a pediatric patient's teddy bear while the patient themselves was going off to sleep. So the IWK, the Isaac Walton Killam Hospital, is the main pediatric center for Atlantic Canada, and certainly for neurosurgery, that would be the main site. Trauma, again, we're kind of the tertiary quaternary center. One of the things that's been really fantastic in the last year or two is that there's this, we have a really good trauma service that was relatively new. It started up a couple of years ago, ICU driven. It's been a huge help. And they really like our group. They have loved our residents' sense of responsibility and patient ownership and involvement. And it's really made, I think, our residents' lives a lot easier, but also they just, I think, have had a really positive relationship. This is, I think of this as the new library because I grew up in Halifax. Looking at the slide there, I see that this photo from when it was newly built was in 2017, so it's not so new, but basically a lot of development in Halifax over the last decade, a lot of, really funky architecture. This is the quote unquote new library, built to look like a stack of books. it is just part of the rejuvenation of the downtown, a great resource, has a ton of meeting areas. We sometimes have had both surgeon and resident meetings, retreats, journal clubs there. So yeah. In terms of research, very active. As I mentioned, there are at least 6 research coordinators that help with these different programs. So cerebrovascular, for instance, has a full-time funded coordinator. Neuromodulation, epilepsy, neurotrauma, injury prevention, spine has a full-time one, brain tumor has the nurse navigator as well as a research person. Really all of these, there's a lot going on. And usually I think, the last several years averaging 3 to 4 dozen publications a year by the faculty. So very active in terms of research. Both are really our last 3 heads of division. So, going back a couple of decades now, have very much been academic clinician scientists, really valued that and have been able to really, I think, sell to government, convince them that research is part of clinical care. It is part of bettering clinical care. It is part of advancing where we're at. And so fortunately, there is that protected time to do that. Shot at the downtown Halifax waterfront. So there's been a lot of development there again over the past decade. If anyone's been to visit, the harbor is really really lovely. There's this long waterfront, tons and tons of new restaurants, and just you can rent jet skis. It's a really nice place to be, especially in the summer. No real surprises in terms of equipment. I think we have the basics for microsurgery, that any center would have. We've got the Pentero 900. We can do 5-ALA, Gleolan, fluorescence. We can do ICG. That's Dr. Weeks and myself operating on an AVM jointly. And we've got the Model 2 O-arm, all the usual sort of neuronavigation, using it for multiple cases. I use it for trigeminal rhizotomies. Most of the spinal cases, some of the electrode implantation and DBS and so on. One of the things that happened with our former head of division recently stepped down, David Clark, and that's been continued under our new head of division, Sean Christie, is that there has been, fortunately, funding and a real push for robotics and technology. And that goes back even further to Ivar Mendez, who was big on telemedicine and robotics. But there have been a number of firsts. So about 5 years ago, we were the first to have the stealth auto guide. And then a couple of years after that, introducing robotics in spinal surgery for the first time. On the left there, that's our resident Ali, now in PGY 5, but helping Dr. Christie and one of our graduates, Dr. Leck, with the spinal surgery using the robotic arm. And then in 2024, the ROSA arrived, being used in epilepsy cases. So I think, it's been really nice to see that there's that consistent support from the hospital, from the foundation, from donors and so on to keep driving forward with that technology. I love this slide. Because so this is another shot from the downtown waterfront, the wave. It's kind of an iconic piece of Halifax history and downtown waterfront, and it also has this like lovely neurosurgical injury prevention angle. So that sculpture has been there for many, many, many years, and it has a plaque on it that says, "Please do not climb." And you can imagine, like, everybody climbs it. Kids climb it, teenagers climb it, drunk adults climb it, everyone climbs it. And about, I don't know, somewhere between 5 and 10 years ago, they just kind of went, you know what, we're going to embrace this. And you can see the dark area around the bottom. They took out the cement and they put in this lovely sort of rubber base so that people can climb it and fall off it, and we don't get the broken wrists and head injuries anymore, which I think is great. If you are starting in neurosurgical residency in July, basically all the PGY1s go to the National Neurosurgery Rookie Camp, and it is a fantastic introduction to a lot of basics, a lot of clinical scenarios, a lot of equipment, a great chance to meet your peers from around the country. And that was started at Dalhousie over a decade ago, and part of the vision of Dr. Clark, our former head. And it now rotates around the country. But I think we're still very proud of it. We are big contributors in terms of faculty and teaching, and I think it really does speak to just the long-standing culture of support for learning and for residency education at Dal. So in terms of the residency program, again, like mostly in Canada, it's well, all in Canada, it's 6 years. It's under the Royal College Competence by Design program, which includes the surgical foundations as part of the first couple of years. There is a year that is for academic enrichment, research, sometimes electives, depending on the person's interest. And I think that is one thing that Dal is good at, is essentially being, responsive to an individual's career goals, and path. So for instance, we have trained people who have done a PhD, gone on to open a lab. We have trained people who, a couple of our graduates about 5-6 years ago came to us from Newfoundland, basically already had a job lined up for them at the end of that, and came to us saying, look, I want to be a really good general neurosurgeon. I'm going to be working in the community. I'm not going to be doing research. I want to learn enough to interpret the literature, but I really want to, that's my path. We currently have somebody who's doing a PhD, well, a DPhil in neuro engineering at Oxford University. We've had people do a master's in ethics. We have somebody who's gone on to a critical care fellowship. We've had people do public health, quality improvement, basic science lab masters, basic science PhDs. So I think there's a real sort of willingness to meet you and be flexible about what your interests are. Dalhousie has the clinician investigator program, again, as do many, but our residents have done very well, I would say, at Dalhousie in terms of the CIP support and scholarship capture and graduate studies. I mentioned that we do incorporate a community rotation, generally at least 2 or 3 blocks, that has been really well reviewed and received. We have 1 CaRMS spot annually. One of the things I personally really love about living here is that you can be out of the downtown in like 15-20 minutes. This is part of the lake system that is within the city limits. It's literally about 15 minutes drive from the hospital. You park at the back of Kent Building Supplies and hike in, and you can canoe through this wilderness, and it's just really lovely. Going further afield, there's a lot of, hiking trails, paddling, climbing opportunities, and so on. So definitely, if you like the outdoors, that is a possibility. In terms of CaRMS, all applications are reviewed by the program director and a minimum of 2 other faculty in terms of making a shortlist for interviews. We typically interview around 16 to 20 applicants. The criteria are all on the CaRMS website, basically adhering to the best practices in applicant selection. I know that there has been some discussion in recent years about the value of the personal letter. I love it. I just think it's a, in terms of what you choose to include, your writing style and so on, it is a chance to try and get to know you a little bit, especially if you haven't been able to come to Halifax and do an elective and meet us. And we recognize that with the limitations of the portal and timing and limitations on electives, that not everyone can. Reference letter is important. Obviously, Canada is small. Neurosurgery is a small community. We all know basically everyone who's out there writing letters, just about. And, there's nothing like the personal interactions, so the interview experience matters as well. I'm going to close with just a few activities, things that our residents have done over the last several years. I think we have a really collaborative and cooperative resident group, such that if there's just, 6 consults and emerge, people will divide and conquer. They're not just like, oh, you're on call, this is your problem. People are like dealing pitching in and doing the discharge summaries and trying to get people out at a decent time and so forth, and you know, respecting each other's need for operative exposure, and also just organizing their own social events, which I don't necessarily have pictures of, but so this is a bunch of them going tidal bore rafting as part of an orientation event. They went camping in Kejimkujik. Catherine at the front there, she's our one who's over there doing the PhD at Oxford. She's a big outdoors person. And I will note that Renee, who is in the burgundy top on the back on the right, she's actually our clinician, like nurse educator on the floor. So some interdisciplinary collaboration going on there. Downtown on a sunny Saturday afternoon with a couple of our recent grads there on the left, Jay Hahn, who's currently doing a skull-based fellowship in Calgary, and Mark McLean, who's actually finished a fellowship and come back and joined us on staff this year. And then, yeah, a couple of shots from the annual neurology versus neurosurgery baseball game. So Ellen, who's up to bat there on the right, took a break from being on maternity leave, brought the baby. We all got to enjoy that, and she got to play baseball. And our head of division there, bottom left, being in the midfield. Anyway, fun times. And every year for the Resident Wellness Week, we organize a different activity. And this was from a couple of years ago, where they went to the Rage Room and got to smash things and had a great time. So basically, I think it's a, you know, I think the Dalhousie program is very welcoming. It's very supportive, and I really like our group of residents. And I would be happy to entertain questions about the program or anything you're wondering about if you'd like to join us. Thanks so much for this opportunity.
Great. Thank you so much, Dr. Pickett, for that wonderful presentation and with a nice insight into Halifax life. So we're open for questions. If you guys have questions, feel free to unmute, open your cameras, put your question on the chat. Any questions?
I guess I'll ask a question. This is a question that I ask most of the vascular surgeons that I meet, and it's completely unrelated to CaRMS and the program. It's just I want to know, as a dual trained vascular surgeon, what's the job, what's the landscape of the job as a dual trained vascular surgeon, and how do you choose to become one? And then it's just because in my head, the reason why I asked this question is because I feel like you have to work with two teams, in the neurosurgery team and the INR team. Therefore, it might be more challenging in terms of finding jobs. So this is just a question that I ask everyone. It's very interesting for me personally.
Okay, well, my answer may be a little more. So I did my fellowship in the UK between 2004 2006, and that was that was a decision we had made. My husband, I was married before med school, summer before med school, and when I matched, my husband like picked up and moved, you know, with 3 months notice to where I matched to. And we had been, and like, that was the way it was going to go. And we had been very clear that at the next step of things, we would go to where he needed to be. And he had at that point switched careers completely from doing a PhD in biochemistry to being an opera singer. And he was like, I need to be in the UK. So I was trying to find a fellowship in the UK, and I decided that I want to do vascular. And if you're going to do vascular in this day and age, you really need to be dual trained. You know, I don't think you will get a job doing purely open vascular unless you also have, say, skull base. You could be like skull base and open vascular, but you need two strings to your bow. And I didn't particularly want to do skull base. Won't go into the why, but that's, you know, it just wasn't my thing. So I wanted to be in England, and it was very difficult because the climate at the time was purely like surgeons did not coil. It was massively political. Pretty much every unit turned me down, except for Manchester, who was willing to give me a little bit of an in, and even they were dubious, and they took me for an open fellowship for the first year. But I had had such a wonderful exposure and experience to that team-based approach in London, Ontario, and really saw the value that you know, that combined wisdom could bring to a patient. And I think especially if you're working in like an AFP or, salaried situation where it's not about, I get paid the same if I coil it, clip it, leave it alone. It sort of takes that piece out of it. And it's not necessarily about ego either. You're working with colleagues and it's like, what is best for this patient? And I showed up in Manchester and there was a lot of pushback and there was a lot of, it was an interesting year. But I think what they saw there was this huge benefit from having the neurosurgical perspective, in the radiology world, and from having sort of the again, just that perspective, again, from both sides. I'm repeating myself, but it was so valuable that basically they then agreed to take me on and train me, and then at the end of that fellowship, they took me on staff, and I worked there for 2 years, and I was the first surgeon in the UK to have a dual practice. And when I left, they actually sought out my previous open cerebrovascular fellow, brought him back, trained him in endovascular, and he runs the unit there now. And I think working with the two teams is honestly a delight. I mean, I think it gives you just this flexibility. If you have collegial people, I think there are some units where it isn't, even in Canada. And I know because I've spoken to some vascular surgeons here who are like, wow, that's not the relationship we have. But I think, you come to this with a collaborative mindset, and this is what's best for the patient mindset. I'm sorry, I'm not sure. I don't want to take up all the time on this, and I'm not sure I've answered your question totally about the job market, but I think that if you go into it with that mindset, you will find a place that is open to that. Yeah.
Perfect. Thank you. It's a very interesting story. And I think it's a very interesting, like the marriage of the two fields to come together to do that. I think it's great. Thanks.
Well, and I think, there are so many overlap areas like spine, neuro and ortho, and I think each brings a slightly different perspective. Neuro is so much more respectful of the things inside the dura. Historically, ortho has been so much more respectful of like things like sagittal balance and angles and stuff that neuro perhaps wasn't. And now I think, so many of the fellowships are joint. As I said, our fellows are spending half their time on neuro, half on ortho, and I think just getting that sort of, broader perspective on things. Yeah.
Wonderful. Thank you so much for that response. Any other questions? Okay, so yeah, go ahead.
Well, I was going to say, I'll close by saying if there are any questions that people think of afterwards, feel free to email me or our program admin, Catherine Anderson, and happy to answer those and hope to see some of you later in the year.
Wonderful. Thank you so much, Dr. Pickett. Thank you so much for joining us tonight and for the wonderful presentation and the thoughtful Q&A. We're nearing the time for our next presentation, so we really appreciate you coming out and taking time out of your night.
Thank you so much for the invitation.
Of course, happy to have you.
Thank you so much, Dr. Pickett.
Can you guys see just a blank screen and maybe my first slide now?
Yes, yes.
Okay, perfect. So thanks for that introduction. My name is Elisa Almojuela. I'm presenting on behalf of the Winnipeg Neurosurgery Residency Program, as you mentioned. My disclaimer is that I'm not Dr. Drapeau. I'm not the residency program director. She is currently halfway across the world, so I've been tasked with presenting on her behalf. That being said, I am pretty heavily involved in the residency program as the competency director and the wellness director. So hopefully I can give kind of an accurate summary of the program and answer any questions. And I also just saw two of my residents come on the line, Dr. Phil Kowalik and Dr. Sam Ollet-Talker. So if there's any questions, they can help chime in about anything at the end as well. So I just have some slides here. So just a basic outline of kind of who encompasses our program. Currently, we have 9 residents. We're, a moderate, medium-sized kind of program. You can see that each year we take 1 to 2 residents. And for this upcoming year, we do have another 2 PGY1 positions available. Right now we have 13 attending faculty members with pretty great representation across all subspecialties. We're supported by one program administrator. We've got several nurses that help handle our outpatient practices, large number of administrative personnel, surgical office assistants. So I'd say we're fairly well supported here. I've got a few slides here just kind of showing our faculty members, which I'll go through fairly quickly, just to give you all a sense of, who we are and our academic involvement as a group as well. So first there is Dr. Drapeau. Again, she's our residency program director. She is a pediatric neurosurgeon. Dr. McDonald is our section head. He's also a pediatric neurosurgeon and does epilepsy as well. I'm up there. Again, I'm the competency director and wellness director, and I'm also the co-director of our Winnipeg Spine Fellowship program. Dr. Biko serves on our competency committee as well. He does primarily oncology and skull base and also is quite involved with our Gamma Knife program. Dr. Kazina is a pediatric neurosurgeon. He previously was the residency program director and currently serves as the surgery head of child health for Manitoba. Dr. Dhaliwal is our undergraduate medical director. So if any of you have come by, you've probably interacted with him a little bit. He also does spine. Dr. Barrington is another one of our spine surgeons. He was previously a section head as well. Dr. Silvaggio is one of our vascular surgeons. He also does endovascular work and has a Gamma Knife practice as well. Dr. Kaufman is a vascular surgeon. He also does oncology and skull base. He actually has one of the largest practices in Canada for microvascular decompressions for cranial nerve disorders like trigeminal neuralgia and hemifacial spasm. Dr. Abdul Salam, another vascular surgeon, also does endovascular, and he also leads a anatomy and surgical approach lab for our residents. Dr. Zeeler focuses on traumatic brain injury, and he is a clinician scientist with us. Dr. Fomenko is one of our newer recruits. He primarily does functional and epilepsy. And then we have another new recruit, Dr. Galdino, who's going to be doing some spine work with us as well. So if you've been counting, we've got 3 vascular surgeons, mix of open and endovascular, several spine surgeons, oncology, functional. So really great representation from all subspecialties. This is a slide on the specific goals of the neurosurgery program, but at the end of the day, this is probably very similar to every other program in that we really have a standard for trainees that's determined by the Royal College. And our primary goal is really to produce excellent neurosurgeons who will excel in their future careers. We are a fully accredited program. The residency program is governed by the RPC committee, which includes several attendings as well as typically 2 resident representatives. Progression through training is determined by the competency committee as well as the promotion and remediation committee. All our residents are employees of our provincial health authority called Shared Health, and they are represented by CaRMS, which is the governing body that helps residents negotiate things like salaries, duty hours, and several other policies, probably very similar to other provinces. This is an outline of what a typical 6-year neurosurgical residency in Manitoba looks like. You can see many of the core off-service rotations are completed in the PGY 1 year. So that includes ICU, trauma surgery, neurology, to really help residents get a lot of the baseline skills under their belt in terms of just taking care of sick patients. Plastics is usually done a bit later in PGY 2 after residents have already spent some time in the operating room on neurosurgery. And then neuropathology blocks are done typically later in residency and sometimes can help facilitate study time before Royal College exams. Our PGY 4 year tends to be a flex year. So that year is really open for residents to either pursue subspecialty electives or research. Whether that's a single research year or multiple years to pursue advanced degrees. It can be done locally or sometimes outside of province. And that year tends to be very personalized, and we kind of, come up with a plan on a case-by-case basis. Residents do follow the competency by design curriculum set by the Royal College. And so there are regular assessments done through our online system, as well as regular meetings with the program director and competency director to evaluate progress throughout the year. This is an example of a resident report card that gets filled out. So we try and check in with our residents fairly regularly, not only with respect to clinical competency, IDERs, exam results, things like that, but also things like career plans and research activities, rotation plans, study prep, wellness issues, any sort of personal goals as well. So, I hope this shows that I think one thing our program does really well is really invest in our residents, not just in terms of making sure that they excel on exams and things like that, but also that they are staying on top of things like career and fellowship planning. So listed here are some of the more specific components of our academic curriculum. So we have practice oral exam sessions as a group, at least once a month, quality assurance rounds once a month. Journal clubs we do about quarterly, and we try and do them outside of the hospital. There's Department of Surgery and Neuroscience grand rounds. We run through our brain school curriculum, the entire curriculum about once every 2 or so years. We've got dedicated neuropathology sessions as well that are generally quite well received. And we also run an anatomy and surgical approach lab for the residents. So, those are kind of specific things that add to resident education, but of course, there's a lot of education and learning happening in the operating rooms, on the ward, on call, things like that. I will say that our residents are often first assist for cases at a very early stage. I've had our current PGY1s be my first assist in several cases so far this year. Sometimes we do have junior resident, senior resident pairings in the OR, which is what is shown in that top right photo with the attending kind of hands off. I would say this is a little bit less common just because of our program size, but when it does happen, it's quite helpful, I think, for our seniors in terms of just developing teaching and mentorship skills going forward. Our residents also start to take solo first call in their PGY 1 year. It's a graded approach, so we kind of assess each resident on, again, a case-by-case basis, but the goal is to have residents take solo call, certainly by their 6 months or so into residency, which I think really makes for great learning for them and really increases a sense of independence for them early on. Something interesting about Manitoba, I think not many people realize, but we actually have really all the bells and whistles and some of the most up-to-date technology available for our surgeries, despite, again, being kind of a smaller to medium-sized program. So we have access to both cranial and spinal navigation that is used regularly. We've got an intraoperative CT scanner, intraoperative MRI suite. We have the ROSA robot for SEEG placement. We've got a really robust Gamma Knife program, and we've just started spinal endoscopy cases as well, which at the moment I believe is only being done in 3 other Canadian provinces. So really, I think Manitoba is at the forefront of all this technology. And I think, did you have a question? Maybe not. But I think having this technology can really change the game in terms of how our residents are trained and the kind of skills that they develop. For interested residents, there are several opportunities for research as well. So listed here are just some of the active research projects being done by our faculty. Some things to highlight, as mentioned, Dr. Zeeler is a clinician scientist who really specializes in traumatic brain injury, and his lab has produced a lot of meaningful work. And we recently had a resident do a PhD with him that won several awards as well. Our site also participates in several national and international projects, for example, the Canadian Spine Outcomes Research Network, and we are set to get involved in an international randomized controlled trial on spinal cord perfusion pressure imminently. We've also had residents pursue research interests outside of Manitoba. So if they've identified a supervisor or special interest that's better pursued outside of Manitoba, that's also an option for them that we'll consider. And lastly, wellness is important. We appreciate that for our residents to perform at their best at work, they also need to be supported, socially, mentally. And so our residents have access to several resources to help manage things like burnout, anxiety, depression. There are several wellness topics that are covered through the Department of Surgery Grand Rounds. And we have several social activities kind of listed here that happen throughout the year as well, that really give residents the opportunity to spend time outside of work with colleagues, both among themselves and also with us as attendings. In Manitoba, it's expected for residents to take their post-call days. It's understandable when residents take sick days, so there's really no kind of hidden curriculum when it comes to those kinds of things. And there really is a zero policy for mistreatment here. I'd say we really strive to have kind of an open door policy where if there's any issues at all, residents should feel that they can bring things up to us and that we'll provide support in whatever way we can. So just to end off, some group photos from the last year-ish of some of our outings. Top left was a wellness journal club hosted at my house. Bottom left was a summer barbecue at another faculty's house. On the right side are some photos from Jets games. So every now and then we're lucky enough to get a box for our neurosurgery group to get together and cheer on our local Winnipeg Jets. We've also had several summer retreats at one of our attendings' cabins. That photo was taken in the beautiful Lake of the Woods area. So we get together for a weekend, spend time out on the water, fish, get into nature for a little bit. Our last retreat was a little bit higher adrenaline where we went go-kart racing on 50-kilometer-an-hour go-karts. That was a lot of fun. So again, I would say our residency program is quite busy. Our residents work hard, but we also try and have some activities that help them foster positive relationships within the group. And that's really all I had for formal slides. I have our website listed here. Feel free to check that out. We do have an Instagram page. I've listed Dr. Drapeau's email address as well as my email address. These are some of my favorite spots in Manitoba. Happy to talk about that, but maybe I'll open things up to the group to see if they have any questions. If Phil or Sam, I think you guys are still on the line. If you guys have any comments, feel free to jump in as well.
I just posted my email in the chat as well if anyone wants to ask more resident-based questions, but otherwise I don't really have much to add to what Dr. Almojuela said.
Great, thank you so much, Dr. Almojuela and Sam and Philip. Both of the emails are in the chat for anyone who's interested in contacting them. Appreciate the presentation and taking time out of your busy night to be with us tonight. Is there any questions? Feel free to kind of open your cameras, turn on your mics, and just state the question, or you can put it in the chat and we can read it out loud.
I did have a question. Thank you for the presentation, by the way. I was wondering, because you shared some information about the structure of the residency program, I was wondering for residents that along the course of their residency journey, once they realize that they're interested in a specific subspecialty, how does the residency kind of offer opportunities for residents to continue to explore that? For example, are there opportunities to kind of concentrate their clinical and OR experiences alongside their research experiences on that subspecialty?
Yeah, that's a really great question. I'd say that overall things are quite flexible. So in our residency program, it's not like you have a specific spine rotation, pediatric neurosurgery rotation, vascular rotation. It's kind of just neurosurgery over those 6 years. And so if someone has identified a subspecialty that they're particularly interested in, first of all, we do meet with them and, try and get on top of fellowship planning and make sure they have all their, requirements for that and things like that. But as far as, interest in sort of day-to-day work and attending those particular cases, usually things are flexible enough in the residency group that they're able to do that. To some degree, obviously with the CBD, competency by design each resident still needs to develop their competencies kind of across the board, but certainly if they have an extra interest in one subspecialty, they're more than welcome to pursue that, as long as it's not going to get in the way of other residents' experiences.
Perfect. Thank you so much.
Thank you. Any other questions from the team or from the audience?
Yes, I can ask a question. In terms of the graduates from Manitoba, what percentage stay, and what proportion of graduates end up working at another site? I mean, like leaving the program and finding job in another place.
I don't know if I can give you specific percentages, but I can say, off the top of my head. So I'm from Winnipeg. So I've been able to come back. One of our newest recruits is also from Winnipeg and has been able to come back. Other recent grads, have been able to find jobs either in Canada or a lot of the time in the United States. That's something that we're hoping to try and improve on, just in terms of local recruitment and, trying to find pathways to allow residents to stay with us, because we train them for 6 years. We know they're great residents and we want them to stay with us. So that's definitely something that we're trying to improve on and something that's been identified. Yeah.
Thank you.
Great. Well, thank you so much. If there are no more questions from the team in the audience, I think we can call it a night here. What do you think, Farbon?
Yeah, if there's any other questions, you guys can go ahead. But if not, thank you so much for joining us, Dr. Almojuela, and the residents, Dr. Tucker and Dr. Kwolek, who was previously a part of CaMSIGN. We're happy to see you again.
Thanks for having
Happy
us.
to, yeah.
So we have the pleasure of welcoming Dr. Persad. We had the pleasure of having him join us as a resident, and now we have him join us as a staff, replacing Dr. Ahmed, who's also across the world. And we have the pleasure of having Dr. Persad. The floor is yours. Go ahead.
Sounds good. Thanks for the introduction, Farbod. It's a pleasure to be here. I just let Jack Sue in, and I see Ori Adeyinka is here. So a couple of our residents have joined in, and perhaps a couple more people from the program will come. I think that would be very nice. And it looks like our chief resident might be able to come too. I'm actually on call, as you might be able to tell, and Nicole Coote, who's our chief resident, is on call too. So Uzair Ahmed couldn't be there today. And for all of you guys, and Farbod, maybe if you could manage this, that'd be good. I'm starting to get into it. I wanted this to be pretty interactive. We have a couple of our residents here. I have some slides that are based off of what Dr. Lissa Peeling, who was the program director before Uzair did, and I stole many of her slides, and I don't do cerebrovascular and endovascular neurosurgery, so I'm going to delete that right off the cuff. But the slides are sort of to give you an introduction to our program, and we can take it from there. Anyone interrupt any time to just chat, ask questions, whatever. So some credit to Dr. Peeling, who did a lot of work to building the program into what it is now, and she's quite proud of it, and I'm quite proud of it too. And Dr. Ahmed is our program director. He is in, I think, Iran right now with his family, so he sends his regards, and he wishes he could be here to talk to you all, but I'm sure that we don't have to feel too bad for him traveling halfway across the world. This is a little snapshot of our faculty. We're 9 neurosurgeons as faculty, and we cover all of the domains of neurosurgery in terms of subspecialty coverage. And then these are our residents. We have 7. We currently have 1 PGY6, 1 PGY5, 2 PGY4s, a PGY3, and 2 PGY2s. And a couple of them are in attendance. So I'm sure you'd be happy to hear from them, and they'd be happy to give their perspectives. And we have 3 neurophysiologists who are part of the division as well. This puts us in a pretty privileged position in terms of doing things like complex spine, skull-based surgery. and awake craniotomy and that sort of thing. We don't have any struggle to look for neurophysiology support and muscle monitoring and that sort of thing in the OR from day to day. It's just a quick text message to get these guys involved for very complicated cases. This is a map of all the faculty and where we did our respective fellowships all over Canada and the United States. Most domains of research are covered. There's a couple of labs that are around on campus. We can talk more about that if you want. There's like a ongoing publications wall that's outside of the resident library. There's a research year for the residents. It's a 1 year research rotation for at least a year. Many do a master's degree or some sort of specialized program. We haven't had too many people do a PhD, but we're open to it. We have the clinical investigator program like many other programs, and I think most academic centers have it, which funds you at the income level of a resident to do graduate student work, which is good because graduate students get paid peanuts. And it supports you for a number of years for your research programs. After that, it sort of depends on getting grants or stipends on your own, but the division is happy to support as much as we can. Some publications that have come out of the division by the residents in the last couple of years. They've been busy at it. So then what the residency looks like. So in the junior years, it's a sort of an introduction to the discipline. It's sort of the same everywhere. So a lot of neurosurgery blocks, as well as other surgical and medical blocks early on to get used to being a doctor. One of the benefits of being a resident in Saskatchewan, which you'll hear from many of the smaller programs, BC is like this, Winnipeg is like this. Because of the small number of residents, you get a comparatively high amount of OR time in order to build your skills up early on. So this is a picture of Nicole Coote, our current chief resident, operating with Ori and Natalie. They get in on a lot of cases, and there's graduated responsibility. So even if there's only a small number of cases a day, because the seniors become competent early because they get early operative experience, they end up being able to do a lot and letting the juniors do a lot. Like I did a fairly complicated case today, and I think I didn't scrub in until after the sylvian fissure had already been dissected and like the insula exposed. So that's not necessarily common, I don't think, across the nation. And I'm quite proud to say that from an early level, the residents here get quite a lot of operative exposure. Intermediate years is a lot more graduate exposures. This is a picture of Jack Sue, who's in attendance here, operating through the brain path tube on a fairly complicated epilepsy lesion. It wasn't very large. It's a subcortical white matter lesion that ended up being a low-grade glioma. But we chose to do the brain path because it was small and because the kid had epilepsy to avoid irritating her cortex much more. And he did much of the setup and was able to kind of gun his brain path skills. There's some specialized rotations like cerebrovascular and endovascular, neuroradiology, pathology, which aren't surgical, but go a long ways to sort of rounding out your knowledge base and making you a more complete physician. And then in the senior years, you get a so this is a picture from today, actually. I wasn't scrubbed in, so I took a picture of Nicole, PGY6, and Braden, PGY5, splitting the sylvian fissure and exposing the circular sulcus of the insula to do an amygdalohippocampectomy. They were doing a good job, so I wasn't too worried. And there's a lot of surgical independence because you spend so much time building those skills up and earning trust. So that's another thing I should touch on, actually, is because there's 9 faculty and 7 residents, not a lot of people, that each of the faculty members kind of has a pretty good idea of what each of the residents can do. And that leads to a lot of trust and a lot of oversight rather than, how to say, hands-on practice. The residents become quite reliable and like kind of know the way you like to do things. And as a resident, you will grow to be able to learn the styles of each of the different surgeons and be able to do most, if not all, of the procedures that occur in their rooms. There's also the exam in the senior years and figuring out fellowships, which our people have done fairly well at. I can talk to that a little bit more later. This is a video of a senior resident clipping a previously coiled MCA aneurysm with the faculty member not involved, actually. Just to show that some people other than BC clip aneurysms. And then I'm not a cerebrovascular surgeon, so I had to show one of my cases too. This is an insular glioma that I did that the chief resident took the lead on, and you can see it's a pretty good resection of that flare intense signal. I just have a lot of pictures. Like I'm quite proud of the residents in the residency program, so I put a bunch of things together to show you guys sort of what it's like here. This is Patrick and Jack operating in my room. This is Jack operating with one of the ENT surgeons doing an exposure of the nose for an endoscopic case. The residents hanging out, Jack doing some paperwork. He's really good at that. You can ask him about his paperwork. He's here. Nicole and I, and Braden and I. Braden and Jack operating on his own. You can see he's showing some ankle. It's a whole bunch of people. Luke and Annie, Patrick, sorry, Natalie, and then there's some other people in attendance. We're putting a brain path in here. And then this is Natalie taking some sort of absurd picture with my phone, I think, actually. Patrick in 2 different shots, operating on some sort of infection in the head. And he was using the least ergonomic stance that he could possibly think of, so I thought that this was a picture that had to be taken. It's Nicole and I with Luke in the background, Dr. Hineni, Eva and Braden operating under the microscope. I think they're exposing a vessel for a bypass. Eva and Patrick took a picture of themselves operating and then framed it and put it in the library, so I took a picture of that and put it on here too. And then here's Jack, and I think that might be Nicole. It's hard to tell from behind. And then everyone sees each other socially too. So this is at Nicole's wedding, the PGY 6 resident. Everyone is out like having a good time. This is a social gathering. This was actually, I think, one of the nurses' birthday parties, and we went out to the bar and had a great time. And then they socialized too. I'm doing a keg stand. This is like the end of my residency. Half day. So half day's changed a little bit. This is Dr. Peeling's slides. There's a lot of things on here. Basically, there's teaching a few times a week. On the Fridays at 7 a.m., there's a curriculum round, or sorry, there's actually neurosurgery grand rounds, I should say, which Dr. Kelly, who will be joining later, who's the provincial head of surgery, has made to share between Saskatoon and Regina to try and get the Regina guys involved. It's sometimes didactic, sometimes cases. At 8 a.m., we do M&M rounds. At 9 a.m., there's shared curriculum rounds between Saskatchewan and Manitoba. The reason it's shared is both to try and get the expertise of both centers, but then also so that the residents don't have to present a fucking PowerPoint every like second week or something. Like that's having been a resident, I just graduated in 2023, so having to be a resident recently, like the worst fucking thing is having to do a bunch of different PowerPoints. Like nobody wants to do that. And then 10 a.m. All the way up to 12 has been co-opted by Dr. Newton, the PGY 5 resident I was mentioning earlier, Braden. He is a bit of an anatomy dynamo, and he's been doing this his own version of Toronto's brain school, where he does this like pretty high level anatomy, like from a basic to a high level of anatomy on everything that's important. I've sat in on a number of them, and they're really good, like temporal lobe, insula, fornix, like approaches to the ventricle, that sort of thing. It's already serving to get the residents up to snuff and like much more familiar with complex anatomy than they ever were before. So that's sort of occupying that time slot. And then at noon, we have oncology rounds, which we've kind of stolen back from pathologists to discuss like kind of holistic management of our surgical oncology cases. And then every other week at 1 o'clock, we have epilepsy rounds, which near and dear to my heart as an epilepsy surgeon. We talk to the pediatric or adult epileptologists and try and get some epilepsy surgical cases going. This is Dr. Kelly, super elite in 2019. He will tell you about Aeroplan and Air Canada if you ask him to. He will probably tell you about it if you don't ask him to. I have really no place to make fun of him because he inspired me, and now I'm a 75K member. And he will inspire you too if you listen to him. He's very convincing. There'll be lots of opportunities for travel. The program pays for your presentations at conferences. There's also Department of Surgery funding for conferences. There's a bunch of courses you can go to. A bunch of them are listed here. Braden went to the Lougheed course recently. I think Jack was at the spine course recently. He can talk to that a little bit. There's a resident retreat every year, which they just went and basically got drunk and then went on someone's boat in the lake. Kind of fun. They're all friends with each other, so it's good for the most part for them to hang out. And yeah, that's the slides that I prepared. This is my contact information. You can text me, you can email me, whatever. I was really hoping to leave this mostly for discussion and try and get you guys to get the perspective of the residents who are around too anyway. Jack, you're here. Ori?
Great. Thank you so much, Dr. Persad, for the thoughtful presentation. So the floor is open for discussion and for conversation with Dr. Persad and the residents. So feel free to open your mics, turn on your cameras, and just partake in the conversation. Or if you have any questions, bring it up, or you can put it in the chat.
Oh, Eva and Natalie are here too, by the way. There's a number of our people here. I'm really happy to see that.
Oh, that's wonderful.
Yeah. So you can ask questions to the resident. You can ask questions to me. You can ask about what we do in Saskatchewan. We don't actually ride moose to work, despite what you might think. I'm just going to leave this on here because I'm proud of these guys for today. This was a well done case.
I have a question.
Yeah.
What does your call typically look like? Maybe someone who isn't me can answer. Is Jack around?
Yeah, it looks like Jack, Ori, and Natalie are all on there. Nicole's here too. Excellent. That's pretty much everyone.
I can answer if no one else wants to. I'm Natalie. I'm one of the R1s. Hi, everyone. So our call starts off in R1. We do 1 month no call just to kind of get a hang of things and get eased into things. And then we do 1 month of call with a senior resident, so buddy call. And then after that, we're on our own. We do solo call after that. Usually we're on call like 1 in 3, 1 in 4, I would say like a couple shifts a week and then a couple weekends per month. Nothing too crazy, probably pretty similar to other programs. We do take our post-call days most of the time, depending. They're optional, you don't have to. And our call, like, busyness can range kind of from anything from no calls overnight to being in the hospital all night. We do home call too, right off the bat from junior residency too. So I have been doing home call since my second call shift ever, and it's been really nice. No issues with that. So anyone else want to add?
Yeah, I'll just clarify a couple things. We do not average out 1 in 3 call. Let me be very clear. Technically by our like provincial, ours is RDOS. I don't know what it is in other provinces. There's para or paro, whatever our provincial contract. As a home heavy call program, we can be up to 9 call per month. We limit ourselves to 7 per month. So you will never do more than 1 in 4 averaged out over the month.
Yeah, Natalie, why did you say 1 in 3?
Do you want to do 1 in 3? I can arrange that.
Why would you
do it? But no. There might be times where you might have, more than 1 in 3 within a given week, but then you might have a week or 2 off of call kind of thing. So it's all averaged out over the month. And then with respect to post call days, as Natalie said, absolutely. Especially as a junior, please, we encourage you to take your post call days. It is not mandatory, but that's not in a way of like, it's not mandatory, but you better actually stay. It truly is like the default is to go home on call after call. But if you slept all night and had a great sleep and there's a cool case and you want to stick around, by all means, you're more than welcome to. We will not kick you out. And we definitely won't make you do a bunch of ward work and all the scut work. But so if you do stick around post call, we want it to be valuable. Don't want it to be a waste of your time.
I want to say 3 things. 1, there's a hard limit on the residents for 7 call a month. So yeah, definitely not 1 in 3. That was implemented by Dr. Peeling, who's the previous program director. to every single Saskatchewan resident on the call, so I'm so proud. And like, you guys can basically ask anything. And 3, Dr. Kelly just came on, so I put it back on his Aeroplan status if anybody wants to ask him about flying around. He pointed out that it doesn't have his million-mile status on there, so I'm sorry for that.
Yes, your apology is accepted. When you do this for London, Ontario, it suggests asking Dave Stephen if he has million-mile status.
We'll keep that in mind. That'll be on Friday.
So I guess I can go ahead and ask a question. So the calls are we had a good discussion about how often the calls are, but then how does the call look like? Is it often that you just don't sleep at all, or is it like you get like 5 minutes of sleep before the pager goes off, or you get like good bouts of like 1 or 2 to 3 hours of sleep?
You guys know this from the rates of conversion, right?
Yeah, yeah, technically. So I think there's a few things. So I would say like a general rule of thumb is like 1/3 you have a pretty good night, a third you're kind of up throughout the night, but you still get a bit of sleep, and a third you're up most of the night. But I'll also add that as a caveat, that changes as you progress through a residency, just by nature of you getting more proficient, you getting more efficient. That I would say, unless I'm up operating all night, very rarely do I not get a few hours of sleep now. And I'm not usually up operating all night. Those are, well, I have not great call karma, but I would say more often than not, you will get some sleep. Like far more often than not, you will get some sleep. Early on, maybe a bit less so because you're not as fast. It just takes you a bit more time, and you're also just stressed from being on call, so you don't let yourself sleep. But that stress goes away
Natalie's very
quickly.
sweet, so she gets paged by the nurses for everything, but Braden doesn't get paged by the nurses for anything because he's
So sweet as well.
Sweet as well.
Yeah, he
Yes.
used to say that. You saw how he just immediately changed what he was saying as soon as Braden told him how it is.
Yeah, so it changes, but I would say the 1/3, 1/3, 1/3 is probably a decent rule of thumb, unless Pat or anyone feels otherwise.
I agree. I think that's pretty accurate. Sorry to cut you off at the end there, but yeah,
No.
I think that's always been sort of an accurate representation. And like you said, if you're up all night, it's because you're operating, which is like, whatever.
Yeah.
There's a question in the chat about the role of robotics in the program. That's a fairly timely question. We're building the robotic program. We've recently put in an RFP in purchasing for a ROSA robot, which many other programs have, but is for stereotactic placement of mostly epilepsy cases, but also functional cases, and can help with the endoscope. Dr. Kelly says it is purchased, so that's great news. We've previously looked into, and Dr. Kelly can probably talk more to this, a spine stereotactic robot, like for screw placement and that sort of thing. Okay, no plans for spine robotics. So we're starting off with the epilepsy and functional robot.
Yeah, we have a pretty big robotics program in the province. The most number of robots per capita, actually, but it's mainly Da Vinci's. Da Vinci and then the Rosa, I think, right? That's 5 robots.
Yeah, there's the orthopedics Rosa as well, right? Like the
yeah, we had a meeting about that last night, but I don't think neurosurgery people are terribly interested in the knee replacement aspects of the Rosa.
I doubt it. And then there's a second part of that question about the advantages of having 3 neurophysiologists and staff. So it's kind of 2 parts. One is that they're all PhD people who are smart and do research. So one of them brings a pretty detailed complex imaging in fMRI program. One of them does a lot of reflexology, and the other one does some reflexology and some imaging, is sort of in between the other 2. They all have an academic program, all involved in teaching. For skull-based CP angle cases, or for awake craniotomy, or for certain types of spine surgery, especially in intramedullary spine surgery, you need a physiologist on hand to be able to monitor those cases. And having 3 of them is a rare privilege that allows us to book those cases fairly frequently without having to wait for somebody who can do some sort of intraoperative monitoring to be available.
Sorry, I just want to clarify. You said reflexology. That's like the thing where you push on people's feet and you cure their heart disease. What do you mean by reflexology there?
He studies electrical reflexes. I didn't know
Yeah.
whatever Braden just said. That sounds absurd. But he studies electrical reflexes mostly of the spinal cord and spinal cord injury, with some cranial reflexes as well. Come on, let's get some chatter, guys. What look, Lyndon Boone has his hand up. That's good.
Hey guys, thanks for the presentation. I'm Lyndon, one of the fourth years from Newfoundland applying to CaRMS this year. Sadly, didn't get to rotate through Saskatchewan, but just had a few more questions just to get an idea what the service looks like. Just curious about, like, on average, how many neurosurgery rooms do you have running every day? About how many residents do you have on service, kind of going to those rooms on a daily basis? And then how big is your typical patient list?
This is a good one for the residents.
I think we usually have probably on average between 1.5 and 2.5 rooms a day, I guess. If the average is probably 2, maybe including peds, because we don't have a separate spine service or peds service. So peds, spine, cranial are all under the neurosurgery service. And then so number of neurosurgery residents on service, probably again between 2 and 4, on average 3, I guess. So with 2 rooms, that means everyone's operating. With only 6 or 7 residents, the distribution of senior to junior can kind of swing one way or the other, depending on the sort of time of year or the given year. Yeah, so that's everything you asked.
Yeah, I'd say patients on service is usually around 35 to 45 typically. Yeah, we do our best to get it lower, but man, they just keep coming. Which is good, I guess. But yeah, the amount of people on service varies wildly. Like in the fall, we're usually pretty flush. People on service, our ones are on service, off service residents rotating through. The spring is always a bit tighter, as you can imagine, with a small number of people. Just 1 or 2 people going away has a huge effect on the on service team. So the spring, it's not uncommon to be 3 people on service and you're working hard, but we have really good staff support when the numbers are low. In the past, when the number got down to 2 people on service, the staff would take the pages during the day and you wouldn't get pages during the day and they'd have to manage things at that time. So we have really good support for when our resident numbers are low. But again, like the benefit of that is when there's 2 of you and there's 2 rooms, even if you're an R1, you're the most senior resident in one of the rooms and you're not getting paid for anything else during the day. So you just get to focus on operating. So it's a really good operative education in that way.
– Angela seems to have a question. Feel free.
Yeah. I was just wondering, is there like on your service, is there like a certain neurosurgical area that you tend to see a lot of and maybe a certain area that you don't see a lot of? Or would you say that the patients are pretty like you get like an equal amount of trauma, vascular, peds, spine? I'm just wondering if there's like anything that Saskatoon tends to get a lot of and anything that they maybe don't get a lot of.
I think you get a little bit of everything. Like this week, it's been pretty general neurosurgery things with the smattering of tumors, but you'll be on call for a week. You usually get a tumor or 2, some traumas if you're on spine call, then a number of spine operations. What do you guys think?
Well, there's only 2 neurosurgery centers in the province, and anything complex comes to us. So it's a pretty true representation of what neurosurgery is, actually, of just a given population. We have all of it, with some of the simple trauma and simple spine filtered out, I guess, for the southern half of the province going to Regina, but anything complex comes to us. So it is just true representation of neurosurgery, I think. Sometimes it feels like it's a lot of one thing or another, but I think that's just the way that cases go.
It's a good question. I'm fairly familiar with North American neurosurgery programs. And I think the trauma volumes in Saskatoon, Winnipeg, Edmonton are very high, just mainly patient demographics and socioeconomic factors. So that's a pretty well-established thing versus out east where there's less so of that, which is good for out east. But the trauma stuff is good. Interestingly, I've been here quite a long time, and I used to have a lot more assaults, blunt force trauma to the head that has somehow converted to penetrating trauma to the torso and abdomen. So the trauma service sees, I think it's 850 patients a year at University Hospital. Regina's a little bit less, but trauma volumes are pretty high. The population of the province has also grown to 1.25 million people, and we'll see what the new federal, it's coming out, I think, in the budget, the new federal immigration numbers and targets. Saskatoon grew a lot during the last 10 years. I think we added about 100,000 people. And we anticipate, at least at a government level, significant inward migration to the province, particularly because of cost of living issues in British Columbia, Ontario. That's driving that population. So it's become quite a bit busier, and that I think is quite relevant to that particular question. The slower services would be pediatric surgery. The numbers come in at about 100 cases per year. The residents have continued exposure to that, though, throughout their residency program. And I've been through 2 residency accreditation cycles, 3 as a resident, so maybe even 4, sadly. And that always was felt to be fine by the Royal College Specialty Committee, which I am actually a member of. So I'll make sure the program gets continued accreditation. But that skull-based surgery is pretty busy. Radiosurgery program, we do radiosurgery. Their plans within 2 to 3 years, I think, is the timeline now. We're pretty locked into it for CyberKnife system. So that'll be a big advantage for our particular program as well. So, and I do know the numbers of cases. The room allocation, it is the nationally. When you ask the question about how many cases you do or how many ORs, it is kind of dependent on that. But the neurosurgery service is allocated on a normal month around 30 base OR days for the Royal University Hospital, then 2 to 4 for pediatrics, and then 5 to 10 for the endovascular service is kind of the number. And I think I've been visiting professor at Manitoba, UBC, Brown, and University of Rochester the last 4 months. And it seems pretty similar in most places, actually. The kind of biggest factor, I think, as a resident, you do want to learn to operate. And the best way to learn to operate is every day to operate. And especially if you have cases that don't always go so well, the best way is to get back on the horse and operate again. So I think without question, the residents get incredible operative experience and are technically very good and independent by 5th and 6th year for the majority. Like, I don't know what Braden at your stage or he didn't finish too long ago, but what percent of cases do you think you do independent in your 6th year? 80%?
Yeah, I think the vast majority, like I think Nicole feels very comfortable doing pretty much almost anything quite independently, except for quite high level. Like today, our Transylvian selective amygdala hippocampiectomy, that was mainly a Nicole and I operation until we got pretty deep in there. But I think he feels pretty good, and I feel the same way.
I mean, even operation, just a little bit that you guys didn't do.
It's a bit of a like, you don't want to work unsupervised, but you do 220 GPM surgeries by your 6th year, you're pretty. And I, as somebody that spends a lot of my time in administration now, I sometimes need the residents to remind me to step on the foot pedal the right time to register the stealth and things like that. So the residents are very fast, solid operating. And I think that's a major benefit of the program and something I always strive for since I came back from the States 18 years ago, that the residents, when they went into more advanced fellowships or into practice, that they could keep up with the best. And I proudly say that as somebody that has been to many North American and European residency programs. Are a little different. I don't know, they operate very much there, to be honest, but North American residency programs, I think what's happened is population growth has resulted in lots of the programs the residents get a lot of surgical experience.
Yeah, I did recently fellowships at Stanford University and Western University, and both of those programs are excellent. But I can say that our training and our current residents too compare favorably against residents at those programs for sure.
Is the lack of vascular surgeons has no impact on your training as a neurosurgery trainee. You get plenty of
Yeah,
need.
endovascular as a field is pretty divorced from vascular surgery. I think you might be a little confused, or maybe someone said something a little bit misleading earlier. Yeah.
Okay, great. Well, thank you so much to all the speakers, and this was such a wonderful turnout from the program perspective. We really appreciate the interactive and the thoughtful conversation that was had here. Thank you so much to Dr. Kelly and Dr. Persad and all the wonderful residents at USask. And yeah, there was one last question in the chat which was responded to by Dr. Kelly. We really appreciate it. Thank you so much for lending us your time during your busy night. Yeah, great. Have a good night.
You're calling this because of the Blue Jays game?
Oh, no. We have one more. Last but not least, we have Dr. Riva-Cambrin for our last presentation of the night. So yeah.
Oh yeah.
Okay, great. Thanks for sticking through it, everybody. Probably a long night, and you guys are probably 2 eyes on the baseball game, you know. Okay, great. So welcome to Calgary, virtually. So let's see, why is this working? Come on. Yeah, it's like, try it again. There we go. See, that's why I see what happens when like a boomer tries to use an advanced like animation or something like that, you know? So, okay, great. So, let me just try to move this so I can just see. Great. Okay. All right. I just thought, hopefully, so for those that are not in their final, well, even the ones that are in their final year, hopefully you've come through Calgary, you're about to come through. If you're not, please do. Or if you're coming through town to go skiing, let me know. We can like arrange a tour or whatever, you know, like anything really. Especially if you get locked out with electives or you maxed out your electives somewhere else. Always happy to have you. But those that can't make it, just to let you guys know, Calgary, we're 1.6 million. We're Canada's fastest growing city. And this is always controversial. This causes the most, that's all anyone cares about in my slideshow. When I say 333 days a year of sunny, they're like, and then there's a controversy like Yuma, Arizona says they're the sunniest anyway, but most blue skies. But I'm telling you, it's sometimes the blue sky can fool you, you know, when it's February. Okay, so also just as the city, it's cosmopolitan. Don't let the politicians like that's our superpower is for you to come to Calgary if you're from especially if you're from the east because you've been indoctrinated that they're all hillbillies and they'll shoot you, and there's no multicultural at all. But all of that is wrong and badly wrong. So, but are we a little hickish? Yes. For 2 weeks a year, we're extremely hickish with the Calgary Stampede. And so once in your life, you got to experience the Calgary Stampede. What you never want to do is be the PGY1 on neurosurgery or trauma during the Calgary Stampede. It gets busy. And then, of course, world famous Banff is just in our backyard, and both in the summer and the winter. So all that leads to, like, in these world rankings, most livable cities in the world. Not sure how they calculate this, but it works out well for us, so I show it. Okay, so just those that can't come, we operate out of 2 hospitals, an adult and peds. The Foothills is the adults, so level 1 trauma. All the bells and whistles. The service is gigantic. I always say it's probably the largest single service in the country, like hospital service. Other cities have multiple hospitals, but like in our lowest the census ever gets is 50, and sometimes it goes up, especially during the stampede, to 120. We are one of only 2 places that have the focused ultrasound. We are leading the efforts to build the robot to Mars, put in a chest tube, and the new cancer center, which you can see down there on the right. And then where I live at the Children's Hospital, it's freestanding, level 1, and just rising and rising. As not only is the population in Calgary, but it's a very young population, childbearing. So that's good for peds, people like me. So, this is probably just where the mountains are. That circle is probably a little on the wide side, but we about 3.5 million Canadians. The service, if you come, is chaotic, but it's great. 3,000 cases a year. Every day there's 3 to 6 ORs at the Foothills. The children's, previously, this is an older slide, about 250 cases, but now we just hired our 4th pediatric neurosurgeon, who's a pediatric deformity scoliosis, Dr. Chan. So we're the only place in Canada that has a pediatric deformity program that's both neuro and ortho, and does some really, she trained at Cedars-Sinai, the home of the rich and famous in Los Angeles, and has all the fancy techniques. So we're really excited about that. There's none, I don't know if any programs left in Canada are the old, you don't get to operate till your 4th year. Well, we certainly don't. Like, you'll be operating on July 1st. We have lots of help. Actually, we have 5 nurse practitioners at Foothills. Only one of those are the current ones, but they refused to take a picture together because I don't know why. And then one at Children's, Kelly, with me. So clinical programs, we're really proud that we have every breadth in Canada. So peripheral nerve, Dr. Mita, who's been sick, but he's coming back next week. Peripheral nerve, dedicated neuro, peripheral nerve. He's got his own lab, lots of research going on. Peds, over us, adult hydrocephalus, functional. We have 2 functional, 3 if you count epilepsy. Neuro-oncology, epilepsy, as I said. Our Calgary stroke. They always say if you're gonna have a stroke anywhere in the world, Calgary's the place to have it. Our stroke program, especially our neurologists, are the most aggressive in the world, and something we're really proud of. And Dr. Wong and Mitha are a huge part of that. And then the Calgary spine program is ginormous. So yeah, just some braggadocio, and I think we're the only one that has everything, all the specialties, including like weird and wonderful stuff like ETV, CBC, skull-based clinic, all this other stuff. Project NeuroArm is Dr. Sutherland's lab that works on surgical robotics and AI in the OR, and also has a contract with NASA. Research, we're very culture, a lot of inquisitory minds, so we have a lot of research productivity, and second only to Toronto in size, but per capita higher. Neurosurgery residency training program. So this is what we currently look like. There's 17 residents in the program, and yeah, we're proud that we represent the whole country. So it's like, oh, do you only pick your own? No, we pick the best, and the best no matter where they're from. And this slide shows it, and including Saudi Arabia, which is Canada's 13th province. I'm sure that would be popular. Okay, here's our current resident roster, except for the newbies. So there's Zeal, Crystal, and Luke coming from last year. And then I'm just going to tour you around the residence and then also sort of give you a flavor. So Catherine's our most senior resident. She went into research after 5 years, which is slightly unusual. So she's already written, and then now she's doing a master's degree with John Wong and Alameda and looking at dissolvable stents in rabbits and actually some innovation as well, like how to do patents and stuff. And she's doing a master's. Um, so yeah, so one thing we really proud ourselves on is trying to make Calgary very resident specific. So my hope and dream, and I think we accomplish it, is every residency is a little bit different because it's a little tailored to you. The Royal College sort of sets limits, so you got to do this amount of rotation, so it can't be that radically different. But we try to figure out what you want to do, what you want to be at the end, and try to tailor your residency accordingly. And you can basically, you're limited by your own imagination. So yeah, you'll hear this a lot. I want to produce neurosurgeons plus. I might use the word throughout this that we really want like neurosurgeons plus, like plus research. But research plus is the better than the research because yes, it could be basic science, clinical science, but it's also medical education, it's engineering, it's MBAs, it's anything and everything. As long as you can prove to me how that'll help make you marketable and help you set up programs and make the world a better place, we'll do it. Okay, here, I think I'm showing this because this is our roster from God, that's 5 years or 6 years maybe, geez. Okay, let's walk around and see, have we accomplished those goals? So this is Dr. Poon. Dr. Poon graduated. She did a PhD in Calgary, looking at GBM, and now she got a job here. Same with Dr. Yang. He did a master's degree with me in clinepi, spine, and they're famous picture because he did the first awake spine surgery that went home the same day. So yeah, that's great. Then here, let's see, I'm showing the old guys because then you can see where they land because it's one thing to talk about the residents in the program, but they're sort of unfinished products. So these are finished products. So Stefan Lang just did amazing research in functional and then a fellowship in Toronto with Lozano et al. And now is staff in Vancouver. And Albert, who did a coup d'etat, so he did simultaneous PhDs at WashU and Calgary, and he's now PEDS faculty at the Ohio State University. Let's see, we're going to Magali. Magali did her Harvard med ed, because med ed in Canada pretty well sucks, but not, Queens is not terrible, but like Harvard and Northwestern. And so she went to Harvard. Just ask her. She uses Harvard every second word. But and she's at WashU in St. Louis, and she's the associate program director, set to be the program director in 2 years. Our most recent grads are still from 2 years ago because we didn't have any grads last year. So Maddie did her master's in engineering at Stanford, and then worked with what sounded cool 5 years ago, Elon Musk, Neuralink. Maddie, you saw those monkeys that they put the Neuralink in that were moving video games with their minds. Maddie put those in and has a relationship with Neuralink and Elon Musk, but that's not as cool as it used to be. But anyway, so she just took a job at Dalhousie. So she's now the part of the competition, but she's a worthy competitor. So anyway, so Dal is a much better place because of Maddie. Matt did a health economics and did a fellowship in Chicago with Charbel, like the world's expert in bypass. And his wife's from Memorial, and he wanted to go back home to the Maritimes and go back to Memorial. And yeah, maybe the best teacher I've ever seen, faculty or resident. So Memorial's lucky to have him, and we're slowly trying to make Memorial, it doesn't have its own neurosurgery program, but make it Calgary East. That's our evil plan. Yeah, and then here's some current residents. Jenna did her master's with me in clinepi, and then Branavan, a PhD, and then already had a PhD, and then now he's doing postdoc in New York City with the world's expert in cerebral mets. So why am I telling you all that? I'm just telling you that these are the possibilities. Like you're like, wow, what's the typical route of a Calgary resident? The answer is there is none. It all depends on you. Like, what are you interested in? These are all research endeavors, but I like to bring up Heather. She's slide back. Heather just went into research. So she's like, I don't want to kill rats or anything. She's from Manitoba, loves Manitoba, and says, I'm tired of healthcare being run by nurses and like business majors. Why aren't doctors in charge? So she wants to go back to Manitoba, be a great neurosurgeon, be CEO of Manitoba Health. So to do that, she's got to get an MBA. So she's off doing an MBA at Rotman, full ride. So that's what I mean. Like that's research, in my opinion, but she's a neurosurgeon plus. So when she graduates, it's going to be an easy sell. Like obviously she's targeting Manitoba, but she could target Toronto, Calgary. It's very, very marketable. Our CIP program is phenomenal. We dominate it. We pretty well are the CIP program. The funding for 2 years. To join the CIP program at any university, though, you have to do your research at that university. So you're hearing all those residents that go off around the world to do research. That you don't qualify for that. It's only the people that do part of their research in Calgary. Another thing I like to brag about, or a part of the culture of Calgary is again, this sounded really cool a few years ago, American, like our American brothers and sisters. Yeah, and then Trump. But anyway, like forget that's just a phase. It's just like your older brother going through a phase. Let him go through it. Um, but I love the Americans. I worked there for 9 years, and we learned a lot from each other. The Canadians do things great, but Americans do some things great. So we really pride ourselves in keeping up those connections, those network. I'm in a 14 center network, 3 Canadians, Vancouver, us, and Toronto, but 11 American, and it's really important. You say, well, why are you talking about America so much? Well, 50% of the jobs, the Canadian graduates are going to go to the U.S. So it's really important, and almost 100% of the fellowships are. So we do a ton of visiting professors. We target visiting professors, find out like a resident, it's dying to work with Lawton there. There's Matt and Lawton. And bring him in and let him see how amazing Calgary and the Calgary residents are, and then you're more likely to get the fellowship. So again, networking, we're one of 2 programs in Canada that's in the softball tournament. And now they've opened it really wide. I'm surprised more don't join. But anyway, it's an amazing opportunity. We actually won our first game last year, or first official game. And yeah, we go every year and we do a resident retreat there as well. So every big wig is there. There's a big opening reception and party. And it's just a great place. Like maybe you've emailed Dr. Lawton a couple of times, but you've never actually met. But then you say, hey, can we meet at noon on Saturday after the tournament and just chit chat about the fellowship? Yeah. Like these are just amazing opportunities. Or forget that. Just how about just meeting the other residents from around North America, and then just one day that'll pay off. They're 5 years ahead of you, and guess what? They're in a position to hire you when you graduate. We're also, I think, leaders in wellness. We do a lot of stuff. You see the retreat, the baseball tournament. We're going to retreat again rented like a 16-room Airbnb in Banff. Anyway, but also we do this check-in to see how the residents are doing. It's called the Hone app. It's sort of a check-in for wellness, see how everyone's mental health's doing. If you score too low, then you're contacted by this is a company that does elite sports like Hockey Canada, because it's based in Calgary. And a sports psychologist will call you and say like, what's happening? What is it? Time management? Is it and so you get to speak to a very high level psychologist outside the university, outside us, and we're paying for it. Also gives me a chance to keep an eye, like this is what they're doing, like it's asking you questions. These are their generic business questions and for the Hockey Canada, but we have our own specific questions. And then I get data like this, like, are we up? Are we down? What's our worst thing? Time constraints. Okay, well, we have a skeleton crew. So anyway, it just shows that we really take wellness seriously, and we're actually publishing, so we're actually active in that space as well. Bottom line though, when it comes down to I guess I didn't emphasize enough. Like we're also a huge service and we have everything. So the clinical excellence, our graduates, it's a no-brainer. They're all great when they finish clinically, and then they add that plus. And fellowships is usually not a problem. You can see we've had residents go to all the best fellowships, depending on whatever subspecialty they like. And then this is, this is cut the shit, and here's the turkey. This is our last 28 graduates, and so the national average is 49% stay in Canada. So our average is 54, better. And then there you can see the breakdown between Canada, US, academic, and private. So, yeah, I'd like to see all the different programs, because this is at the end of the day, and even in our last 3 years, 70% have stayed in Canada. Okay, so there's my email. If you have any questions, or you do want to come, you're skiing, you want to come for a day, we can try to sneak you on the service a little bit. I get in trouble a lot for saying that, but hopefully with the new portal that we try to get everyone that wants to come to Calgary to come and do a rotation. But there are, I am a slave to the portal a little bit. So, okay. Oh, that's just my nice graphic that I made. Okay, great. Yeah, open it up for questions. I know it looks like we have 3 minutes, but I think I started late. I'm okay to go a bit late, but unless you guys have probably had a long day, but.
Thank you, Dr. Riva-Cambrin, for the amazing talk. So yeah, the floor is open. If you have any questions, just unmute yourself, write it in the chat. Feel free.
Hi, Dr. Riva-Cambrin. Just a quick question. I'm actually coming to rotate with you guys in the new year in January.
Great.
I was just wondering how your skull-based program is. I had met 2 of your current residents at the McMaster skull-based program, and I was just wondering what it's like at the Calgary one.
Yeah, we have 2 surgeons that do skull base. Dr. Mitha, who's also one of our vascular guys, does a ton, like he was just doing acoustic today. And then, but the workhorse is Dr. Starveld, who's great. He's definitely our best surgical teacher. Like the residents just worship the ground he walks. I don't know why it's not me. It should be me if I hold their careers in my hand. No, just kidding. But I'm only saying that because they're not on. But no, Starvell is an amazing teacher. So he's very, very busy. He's the skull base guy person is usually the go-to, like, hey, I got this nasty tumor, So that he is our go-to. Residents love working with him. He participates in a multidisciplinary clinic, and so there's an endocrinologist. She's really, really involved with neurosurgery. So she's always like, why don't you come to my clinic and learn why you operate and see what these people look like 10 years later. And so that's Christy Lithgow. She's fantastic. We publish a lot with her. Yeah, so that's the program. So not a ton of surgeons. There's 2, and I guess all vascular surgeons are kind of skull-based surgeons. But and Dr. Sutherland would also consider himself a skull. He's everything. He's a vascular guy. And so there we do have a fellowship. We have a graduate from Western is the fellow there now. And yeah, like it's really impactful. Like tons of I think 4 of our current residents, maybe 5, want to do skull base. That's what happens. That's when like who's your best teacher at every site. Just see where the residents are going. Usually that's who. So Dr. Starvell should be proud that the residents want to do skull base, probably because he makes it look cool and like a good lifestyle.
Thank you.
Not that many questions. Everyone's dying to get back to the game, or probably nobody likes baseball, but
I can just ask one brief question. It's what's the first and second year like in terms of the number of blocks in neurosurgery, and what do you start in, and what kind of responsibilities a PGY 1 or 2 has in the program?
okay, well, because we take 2 and then 3, 2, 3, 2, 3. But we might be going to 3 permanently, starting next year. So it depends. Everyone's schedule is a little bit different, but you end up doing the same thing, just obviously at different times. But first year, one block of trauma, two blocks of internal medicine, plastics, one block. I'm missing something. One block of peds. Oh, elective block. So the elective block is a block where you're totally free of something. You might have one or two calls, but it's to finish up old projects that you had from medical school, or more importantly, to start new ones. You know, we want our residents doing projects, you know, even if it's just case reports, interacting with medical students, writing. And so it just gives you a bit of a break. And like, we don't want you to forget at the end of the day the end, you know, so just keep an eye on, you know, because you've got to decide, like, PGY4 is when you go in to do research. And so, you know, from engineering to MBAs to basic science, clinical science, teaching, like, you got to figure out what you want to do. So it's another block to try to give you a break, to step back and look at the forest for the trees. And then PGY2, it's 3 of neurology, 3 of ICU, and 7 of neurosurgery. And then PGY3 is all neurosurgery, but you come over to peds for 3 blocks. And we have a community rotation where you can go anywhere in Canada. Should strike that. Anywhere in the world. Someone's going to Sri Lanka. You can go anywhere as long as it's sort of community based, you know. So Kelowna, Mississauga, Calgary East, aka The Rock, aka Memorial, just in case. I don't have time to look through all the faces. So anyway, yeah, it's just a good chance because, you know, we're the role models, I think, for like academic, but we also want to give you a taste of what community would be like, and to see if you like that too. You know, we don't want to be prejudiced against that, you know, give you an opportunity. Also, it's a chance as a 3, you're under the thumb of 5s and 6s, and some of those 6s are like 85-year-old, no, you know, like PGY for 13s, you know. So as a 3, sometimes you're like, don't have the freedom, like you just feel like you're back at 1, and so you get to go and do a community rotation in Kelowna, and then you're the only resident there, and you get to do higher level stuff. So it's also a way to boost your confidence and get you ready, you know, faster.
Perfect, thank you. We also have a question from the chat from Brandon. What kind of things are you looking for in an applicant? How many papers, experience in a certain area, or in general, what kind of things do you use to check the boxes for an applicant?
You want the secret sauce. You don't forget the secret sauce. You know, no, just kidding. Like, come on, just like what you would want if you were a program director. Like, we want people who are smart. There's some very hard exams in neurosurgery. Like the neurosurgery written exam is sort of known for the hardest exam known to man, or it used to be anyway. Back when I wrote it, it was. I don't know, but so we want you to be smart, like demonstrate an ability to do well in school, you know. But we also like people who are very, like, we can get along with, and like non-psychos. Boy, doesn't everybody want that? What other things do we look for? Like go-getters, self-starters, finishers, people who take on paper. So I don't care how many papers you have, but it is really nice to see like 2 or 3, and especially 1, and it's been published. So that tells me, so just think, flip places. That shows that you're independent enough that you found this project. It's hard to find a project as a medical student, as you guys know. And then do it, complete it, nag the resident, nag the faculty, get them to read it, get them to fix it, then publish it, and then do the revisions, and then you finally get it published. I know, I recognize that. So if you have publications, it's not the amount of publications that's impressing me. It's the fact that you're a finisher and you've dipped your toe in the water. It's those things that impress me in Calgary, you know? I mean, don't get me wrong, there's some people with like 40 publications, that's extremely impressive, but if there's one kid with 4 first authors and another guy with 60 middle authors, I actually like the 4 first author person better, you know, like that's a person that's done been in the trenches. What else? Yeah. Just really like people who have a vision for themselves. Like this is what I learned in the US as well. It's one thing Canadians do most things better than Americans, but Americans usually the one thing I admire about them is that they have everyone's different, obviously, but on the whole, American residents are like more driven. Like they have a vision for their career. It might just be, I want to go in private practice spine and I want to make 3 mil a year and I want a Ferrari and a Porsche for the weekend and I'm going and I want to work in San Diego, California. Like they will just suck up to the San Diego people from the second year and they'll suck up to spine and then they'll do spine research. Like there's a theme there, and then at the end of the day, it seems like the chapter's already written. Like San Diego's like, I guess I have to give this kid the spine job. Like they made it. That's what we kind of want. So like people that are nagging me, I like people who nag me that say like, can you help me? Can you call that guy? I really want to do this and this and this. That's good. Yeah. I don't want to be your mother and be like, did you do your personal letter? Did you, I'm not interested in that. So
Perfect. I guess you pretty much gave up the secret sauce though here.
Like the vagaries, but there is no like there really is. I don't know. Maybe some programs have a formula, number of publications divided by this and that. But yeah, like the other thing is we like I I hate the term. This is where we love wellness. I'm very for wellness, but I hate the term work-life balance because it makes it sound like life is awesome and work is horrible, but you have to balance awesome and horrible. No, like, I like my work. I want you to like work. There's nothing wrong with work. I mean, I don't want a workaholic or something, but um, so yeah, I don't know why I ranted about that, but yeah. So also we have everything too. Like I should brag more that I brag all the time that we're like the most diverse program, certainly in North America. It's easy to beat the crap out of the Americans. They have like 4% women. So like they're all, even the most like California programs are most like 20. So all the Canadian programs are way better than American. But like we have diverse in every way, shape, or form. We're diverse in like yeah, race and gender, that's fine. But like also like basic science geeks, clinical science geek, that's me. We have you heard we have MBA people, we have kind of sporty people that almost made the NHL, D1 athletes. We have major nerds. We have a concert violinist that refuses to play at neurosurgery events because I can't afford her. I'm like, I'm your boss. And she's like, $2,000 for me to play. I'm like, Rena, like, but anyway, so that's what I mean. The diversity, like, yeah. That's why I don't like the question when they're like, what's the type you're looking for? There is none. The type is the driven self-starter, visionaries. Yeah.
Awesome. Any other questions from the crowd?
Okay, great. Is it a good mix between fours, threes, twos, or everybody, or is it? So good luck with all the CaRMS people. I don't know if I see some of you. I can't scroll across that have come by, but okay, yeah. You got all your letters. The hardest part for CaRMS is whipping the staff because you control everything else, but getting those letters of reference is the worst. I remember those days because you're like the balance between being a nag and advocating for yourself. It's a very thin line, like so.
Yeah, I was instructed to harass if needed by
Well,
the people
it's your
asking
life.
letters.
So if you're my child, I would tell them harass, but yeah, I don't know. But yeah, good luck. And then yeah, so anyone too, the younger students, yeah. So please consider coming to Calgary. Like especially if you're oh, I heard you've been brainwashed by the media to say, oh, they're a bunch of hillbillies, they all have guns and they're gonna shoot me as soon as I cross the border. Like, stop it. Like, just come here. You'll be like, oh my God, it's our superpower, because people come and like, this is a beautiful city. It's a huge city, but it's easy to drive through, like blah 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 blah. Yeah. So and we're trying to fiddle with the portal. Yeah. I've been all over the place with the portal. Open it too wide, and then we had a bolus of 6 people, and then we closed it too small. Anyway, I haven't found. I'm trying my best, but the goal is try to get as many people that want to see Calgary and want to participate on our service, and make sure that I'm not a bullshitter on these things. I promise you, I'm not. If anything, I'm underplaying it a little bit. So. Okay, that's enough. Let's go watch the Blue Jays. Yeah. What do you think?
Thank you, Dr. Riva-Cambrin. I think everyone's going to rank Calgary first. And I just want to thank all of my colleagues that are in the session here today that have helped with the organization of this event. With that being said, first things first, we have Dr. Duggal, Professor of Neurosurgery, Division Chair at Western University, joining us. We have Dr. Mastro Leonardo, prefers Alexander. So Alexander, PGY3 at Western, that we have the pleasure of having with us today. Thank you guys for joining. The floor is yours. You can go ahead. Welcome.
Hi, everyone.
I'd like to start by thanking you for organizing this, and all of you that are taking time on your Friday night, where you could be at some great Halloween party or some pre-Blue Jays event. So thank you for coming to hear about boring neurosurgery. We also have Dr. Stephen, who is the chair of CNS, so oversees both neurosurgery and neurology. He's attempting to join at the moment, so if you see a way of letting him in,
I just admitted him.
Okay, great. Well, look, I'm going to let Alex take over. He's going to go through the slides. You want to hear it from your peers, and we will also jump in. But I can tell you from the start that categorically our program is one of the top programs to train in Canada. I've reviewed other programs across the country. I believe Dr. Stevens is the chief examiner, and I can tell you our residents are extremely well trained. They can all operate. They can pretty much do anything when they walk out of their residency program, and they pass their examinations. And those are the two most important things. Now, if it's going to be a journey of several years, well, you might as well have fun. You might as well have good people around you. Not only do we have I think we have a fantastic resident group. We have surgeons that are very collegial, very reasonable people. It will be a very pleasant place because neurosurgery is stressful enough. You don't need the external stresses. We're taking every possibility to help improve your day-to-day. We've hired nurse practitioners for the adult neurosurgery. There's nurse practitioners for pediatrics. Believe it or not, this is going to make an immense difference on your day-to-day. Our program is big enough, but also small enough so you don't have 3 fellows in front of you. You'll get early opportunities. I think our program is unparalleled in what we can give you. So after 25 years, you can look at things, I think, somewhat objectively. And if I didn't believe wholeheartedly this was one of the top programs in the country, I wouldn't say it, but I do. Okay, Alex, jump into these slides.
All right. Hi, everyone. And once again, thanks for having us. I remember a few years ago in the COVID era when I was a med student, this session was so helpful for me. So it's great to be back kind of on the other side of things. A couple slides just introducing our residency group and what we have. Welcome to London, Ontario. I know it's not a place a lot of people have been unless they're from there or have moved here for some form of training. It's a beautiful, diverse area. It's the forest city with more greenery than a lot of other places. We have beaches just an hour away. And this was a picture that I've really liked. I took this one morning walking into work with some purple skies. So we work in a very beautiful place, on a beautiful university campus as well. Like Dr. Duggal said, I tried to pick pictures that really represented how cohesive, agreeable, and how fun our resident group is all together. When you're going about picking a residency program, it's so important that you find a place where you love being with the people you work. You're going to be with these people for hours every week. And finding a group that you can laugh with and learn from is it's a joy and it's a pleasure to work with this group. We host all sorts of other events. This was my co-resident and I at the bottom of the screen here after we won the annual baseball game last year. We attend local events, myself and one of the other residents who's now graduated. And this was us most recently with the guest speaker we had, a past resident of ours. I'm not going to harp too much on this slide, but we're a very cohesive group. Sorry,
May
Dr.
May I
Duggal?
say, Alex, that this represents when you come and you join our residency program, you're part of our family. And we take care of our own. And we will go to the nth degree to put you into the best fellowship program once you get into your residency. So one of the characters on this slide with the very loud shirt, I've set him up personally with the 3 best surgeons in Australia for his fellowship, and he will come back and be a staff at our center, and he will bring back new techniques. So when you have a family member, when you join here, you become a part of our family. It's our job to help you pass your exam, help you find the best fellowship, and then the last part, as best we can, help you find an amazing job through our contact, through our network, through our, and we have that ability. And we have that history.
Just move through. We have as well a wide variety of faculty as well at the institution, all of whom are experts in their respective fields. Dr. Stephen, who's here, of course, he's our chair of the CNS department. He works in epilepsy neurosurgery. Dr. Bolton in open and endovascular neurosurgery. Dr. Riva-Pierre, a pediatric, and does a lot of focused epilepsy surgery in pediatrics. Dr. Duggal, of course, with a broad spectrum of spine and as well endoscopic skull-based surgery. Dr. Heb with skull-based surgery, Dr. Lau with a really robust research program on top of a very high volume functional and epilepsy program. Dr. McDougall with functional and epilepsy program as well. Dr. Megacy being essentially the workhorse of our oncology service here. Dr. Ng, again, a very robust spine practice. Dr. Ranger, a very heavy pediatric practice. Dr. Siddiqui with a strong spine practice as well. And finally, Dr. Yang, an innovator who does a lot of, as well, endovascular and complex spine work too. So what I'm trying to get at with this slide is we cover all the aspects of neurosurgery you could want here. If you come here for training, you won't be lacking any one area of neurosurgery. You'll learn from the best in all fields.
Alex, I'd like to add that over the next 5 years, we're going to have a lot of opportunity to expand our program. And I anticipate over the next decade, there will be 7 new, 7 people, 7 new surgeons added to this group. Some will retire and those will be spots that will fill by, younger, more energetic surgeons. But we are going to have the gamut, and we are in an expansion mode.
Yeah, some of the people in these pictures have grayer hair in reality than the picture is. So there's some soon to retire people in there. You can figure out on your own who that might be.
And thematically, what we're looking for are people, medical students. So medical students who become residents, who may become future staff at our institution. We're looking for people that embrace innovation. They don't have to, but something that they're open to.
because at this stage you're just trying to get through medical school, of course, but we have an environment that's ripe for innovation. Dr. Yang has invented the 70 surgical robot. One of our surgeons that are coming back, Dr. Johnson, he's a mechanical engineer. He's developed spinal implants. We are trying to create thematically a place for neurosurgical innovation. We have a huge budget that is allowing us to invest in technology like I don't know any other center in Canada that we have now 2 robots, we have spinal endoscopy, we have an intraoperative MRI unit that can be done following glioma resection or temporal lobe epilepsy or pituitary surgery. We're gonna equip you with the tools that you will need for your practices 20 years from now and 10 years from now, and you're going to be the first to use them in Canada.
Talked about some of the consultants already. Just for the sake of time, I'm going to move through this slide here. We work at several hospitals in London, Ontario, University Hospital, where we host the bulk of our elective neurosurgery, and then at the Victoria and Children's Hospital, which is where we cover adult cranial trauma, as well as, again, our full spectrum of pediatric neurosurgery. We rotate through Windsor Regional Hospital in our 3rd year for a very high volume community rotation. And we also in 3rd year rotate through Toronto Western Hospital, where we participate in their Gamma Knife program for a month. That's actually another, I guess, a special rotation that we do. Unless something's changed since I applied for residency, this is the only program that offers dedicated time for stereotactic radiosurgery training, something that will be a component of the Royal College exam. And it's something that a neurosurgeon could be asked about, and it's worth having some knowledge in. Our academic program is fairly vast, and we have protected time for education. We have weekly teaching run by our consultants and ongoing longitudinal teaching from peer to peer with our residents. We have case rounds every week covering adult, pediatric, spine and cranial, and we do regular morbidity and mortality rounds that are in part run by the resident group. So we're used to thinking about our own ways of creating system improvement within our own practice. We do in-house training exams 4 times a year, keeping us sharp, testing our knowledge. They're formative exams as well. And we are in the process of building our first cadaver-based clinical skills lab with expected implementation over the coming months. So we're hoping that whoever joins us here next July, we'd have this implemented and ready to go. Over training at Western, you'll do about 47 blocks of neurosurgery, plus or minus a few. We do 3 blocks of neurology, neuropathology, ICU, and critical care. So each, and then as well, we have, again, a vast variety of off-service rotations: neuroradiology, trauma, orthopedic spine surgery, neurology, consult medicine, ENT, plastic surgery, and radiosurgery. The bulk of these are done in 1st and 2nd year for these off-service rotations. And again, me, someone who's in 3rd year, coming off of my junior years of being off-service a fair bit, I felt that there was a lot of value in learning different ways of doing things, different approaches to doing things. So the ability that our program has to send us off-service purely for the sake of giving us learning opportunity is, again, something very, very valuable. And this is the slide that I think would hopefully be the take home for everyone here. Coming away from this event, we want you to understand what our program's strengths are. And Dr. Duggal has touched on a lot of these already. And I think the first one really covers what us, the resident cohort, values the most, is that we have strong independence for clinical decision-making and operative exposure. We're able to work independently on a critical service where we take external calls, we make triaging decisions, and we very much independently run the neurosurgical service. We have the opportunity to review directly with consultants from a very early stage in training. And again, our operative independence is immense from an early stage. We have nurse practitioners on both the adult and pediatric services. This means that during the day, even if you're the resident that's holding a pager, it gives you time and breadth to still get into the OR, get operating, and do the learning that you want to do, which is operating. And the nurse practitioners similarly become part of the neurosurgical family. They become your friends, and then you'll hang out with them outside of work. So it's just further community that you'll get to build during this very stressful time of residency. And again, you'll come out of this program being able to do anything. as a third year, and even when I was a first year, I was always in awe of being able to watch my chief residents go one day from doing complex spine cases to the next day doing 2 carotid endarterectomies, and then the next day working through a complex skull-based tumor through an eyebrow approach or so. And feeling that kind of confidence that our seniors, and that's what we're able to learn and what we're able to learn how to do, instills a lot of confidence in our program from my end. We work with cutting edge technology, like Dr. Duggal mentioned. We have numerous robots for spinal endoscopy. We've recently started using our intraoperative MRI. And then finally, our culture and supportive team environment. I'm sorry that I kind of blasted through these last few. I know Dr. Duggal touched on a lot of these already.
They're worth repeating because they're so important.
Absolutely.
Alex, crafted these slides, and I think he's done a wonderful job. And I mean, this is the single most important slide, I believe, that, we want to create a work environment that is supportive, that's team-oriented, and allows you to be the best you can be. Thanks, Alex. Keep going.
No problem. A couple of our recent advances is Dr. Lau assisting with various stimulator devices. We have Dr. Yang performing robotic-assisted direct lateral fusions. And finally, Dr. Duggal here performing the first spinal endoscopic surgery in Ontario, which again is an accomplishment that he worked very hard for, and it's an absolute pleasure that us residents are able to be a part of this. Another important slide that I wanted to show everyone is what the academic year looks like for people of various sort of levels within the program. You can see a very heavy neurosurgery service for our PGY6s, our chief residents. Our PGY5s are doing a combination of coming on and off research here, back onto the neurosurgery service after their time away from research. And then our PGY4s are doing a combination. Some of them are doing a more research-heavy 4th year, whereas some of them are using this time to pursue clinical practice further. This is my personal schedule here, where again, I'm doing a robust period of neurosurgery, followed by time on the pediatric hospital. And then I'm going for my community rotation, followed by radiosurgery, spine surgery on the orthopedic service, more time with the orthopedic spine surgery, followed by more pediatric service, and then ending with the pathology service. And then in PGY1 in the junior years, we spend a large amount of time off service and on service. So you have time learning neurosurgery, as well as gaining skills from other services. So you can see our neurology, CTU, neuroradiology, plastic surgery, consult medicine, traumatology, neuropathology, and pardon me, my Zoom is blocked, and then ENT as well.
I think one of the important things that Alex has touched upon is that you have a research year. And unlike many other programs, we cater that year for the student's ambitions. So if someone wants to go and do community practice, then that's a year where you could go and get that experience. If you, however, want to go, for example, Dr. Stephen went to Yale. One of our previous colleagues went to Harvard and did a 4-year PhD. And we support that. Number one, we'll open up our Rolodex and try to get you to the places you want to go for whatever you want to do. And we provide an environment where it's student first. And I think that flexibility is very different than many other programs.
And then just moving on to right here with research. We have very close ties with the Robarts Research Institute, which is a world-leading program for medical imaging research. We have opportunities to collaborate with other departments in health and medical sciences for basic science or clinical research projects. We have travel funding for up to $2,500 per resident per year for conference or course attendance, which I just dipped into very easily to go to CNS in LA recently. And then, of course, Western also boasts a clinician investigator program, which provides funding for pursuit of graduate studies for up to 2 years, plus the 1 year of neurosurgery funding that comes with the Royal College Neurosurgery program, to give us the latitude to pursue graduate degrees for those of us that. While our program really offers flexibility, if this is something you're interested in, we can absolutely support it. And that comes to the end of our presentation. I know we only had 20 minutes, and I think I was 1 minute over there. But if there's any questions, we're happy to help answer them.
All right, thank you so much, Alex, for the amazing presentation. Dr. Duggal and Dr. Stephen for joining us. The floor is open for questions. If you have anything, you can, yeah, if you have any questions, you can unmute yourself or write it in the chat and we'll read it out loud.
I just had a quick question. Thank you guys so much for the presentation. Do you mind talking a little bit more about your cerebrovascular neurovascular program? And do you guys, as residents or staff, have time to have residents in the IR suites doing aneurysms and stuff like that?
I can start by answering that as a resident that's explored there, and then I guess Dr. Duggal and Dr. Stephen if you want. But so for IR exposure, we actually have a very, very robust neuro-IR program, and it's a very high volume one as well. We have the neuroradiology blocks. We do one in first year and one in second year, and during that time, we're encouraged to go to the IR suite. I'm not someone whose career is planning on going down the IR route, so I take purely an academic interest as someone who finds it really cool. But during that time, I was able to, do groin punctures, drive wires, assist with those procedures, even sometimes once or twice with just a consultant there. So if it's something you're interested in, and if it's a passion of yours, again, me as someone who's not even particularly interested in pursuing a career in it, had that exposure, I think as well, it's something that we'd be able to support.
Those are good points, Alex. So you have to look at the history. Western has always been traditionally the place for training in vascular surgery with, of course, everyone knows Charlie Drake, but the icons of endovascular came out of our center, like Fernando Vinuela. There was a period of time where this was the epicenter of the world for vascular. And we have, during this period, developed an extremely close working relationship with the neuroradiology team. So therein, I think, is one of the big benefits, right? So in some centers you go and you need an MRI and it's almost a battle. Here, these are the people, these are your colleagues, these are your friends, and it's a very, I think it's an amazingly supportive relationship we have between the two groups. So, for example, if you had a particular interest in IR, maybe that 1 year that you have off could be dedicated to an enfolded IR, really, a mini fellowship. Those are the options that can happen because we have such a great relationship with this group.
Thank you.
Okay, good. Okay.
I guess I can ask a question also. So
Maybe
you
take that.
mentioned, sorry?
Oh, I was just going to maybe suggest taking down the slide.
Oh, sure, yeah, we can do that for sure.
Yeah.
So you mentioned briefly about residents taking critical and being involved in the triage process. Can you elaborate on that? Because I feel like that's a very interesting aspect of training to be able to be involved in that kind of decision making. I think it's really cool.
Absolutely. So it doesn't obviously start right away in residency because it's a very independent activity. But from after a few blocks of neurosurgery, we start working through the critical service, which is essentially, in Canada being a very diverse geographic country, we're working in an academic center and we have a large peripheral catchment area. So if someone comes into a peripheral hospital requiring neurosurgical care, they critical or they use what's called the one number system to call into our London hospital, and it's up to us to take those calls, to ask questions, to interpret the investigations at the time, and then determine essentially a triage, to triage when they should come to London, if this is someone that requires neurosurgical intervention or follow up, and to use that system. So again, I think it's a great way for us to practice our neurosurgical triaging skills, additional practice reading scans, and communicating with other healthcare providers, especially those that aren't necessarily from a neurosurgical background or from those that are seeing lots of neurosurgical pathology. I see Dr. Steven, your hand is raised if you want to add to that.
Yeah, just further comment, like I'm on call tonight. But so it's a skill that you really underestimate when you're in training, like having to deal with like calling some guy on the phone who doesn't know what they're talking about, and then you're trying to figure out like, is this somebody, do I need to see this person or not? And you're going through the films. So so how it works is that the resident will do that, and then depending on their level, sometimes they'll call anyway and say, "Hey, Dr. Steven, what do I do about this?" But as they get senior, my observations, they tend just to prefer to do it on their own, basically, because if we take the call, we just accept the patient anyway. So they prefer to have a little more control over, how much work they have to do, because a lot of the patients don't have to come down, frankly. They can be managed locally. So, and then in the morning, there's an email that goes out, and then the staff on call, like tomorrow morning, I'll go through the email, look through all the outside calls, go through the films. There's some issue I have with it, I'll call up the resident and we'll sort it out. So yeah, it's been like that for years. I liked it when I was a resident. Residents still do it.
Yeah, we both Dr. Steven and I did it as residents, and we were unique in that because most centers don't give you that opportunity. And it's actually, you learn so much about how to triage by volume, right? Because, in my own practice, I might get 60 to 70 referrals a month where I'm triaging it. And that's a skill that I had learned already in residency. It was something easy for us to understand and kind of get our head around. So when people call you, you know the questions to ask. In a way, you're kind of prepping for an exam question, right? So you're kind of going through sequentially. What do the questions I need to ask? What's relevant? What's not relevant on the history and physical? What have they done? What haven't they done? And so you're kind of going through every time you do this, like a little. You learn the algorithmic approach to taking on a question or seeing a patient. So and it's yes, you're not actually examining the patient, but and I know a lot of the stuff that you need to kind of get your head around can come through a very solid history and someone reporting some imaging findings, and you can have a pretty good idea of what you're dealing with. So I think it's very valuable.
Awesome. Thank you for your response. And I agree. It's something that I've noticed as a student on rotation, that it's a very important part of the decision making, and it's always cool to be involved in that kind of process. I have a question. Sorry, we have a question from the chat that says, "Hi, thank you so much for your time and the information. I'm very much interested in interventional neuroradiology and endovascular neurosurgery. However, as an IMG, it is pretty competitive to match into neurosurgery. Do you have any tips for Canadian students studying abroad?"
Is the question asking like, I'm not sure, is it asking to do interventional or to match? I was kind of unclear as to what the question is exactly. If we're doing endovascular neurosurgery, that would be obviously dependent on doing a fellowship, residency first, and then getting a fellowship. But I'm not sure if that's what the question is asking.
You can feel free to unmute yourself and clarify that if you want, Rojan.
Sorry about the confusion. I was mostly just looking to see what are some things that we could do towards being able to match into neurosurgery, and being able to, get publications or get research or get more involved when it comes to minimally invasive neuroradiology or endovascular neurosurgery, and basically, working towards that goal.
You want to tackle that, Alex?
Yeah, I can talk a bit about it. And I'm not an IMG myself, but I do know the difficulties of being an IMG applying for neurosurgery in Canada. There's not that many spots. I know Toronto has one. I don't know which other schools offer one. But to specifically answer the question about how to learn more about endovascular and interventional neuroradiology, my best bet is there's really no way around emailing people and contacting people in those services, whether it be the fellows that are, working through that day to day, or the consultants as well. learning about what they do, see what sort of volunteer and shadow opportunities they have, and then seeing if there's research projects you're able to help out with. I think this goes for CMGs just like it was when I was an applicant as well, but there's always a bit of an uphill battle of reaching out to people and trying to find opportunities and make opportunities for yourself. And I think it's just where you have to start, and then you build from those base building blocks and go from there.
Yeah, and I would say like IMG, as you know, is tough. A tough ask. It's tough to get into any specialty, frankly. Unfortunately, but that's the fact. I would say the priority is to get into a neurosurgery training program. Like just that is the number one priority if you're interested in some subspecialty in neurosurgery, is to get into neurosurgery to begin with, because you need one to get into the other. So I would say that would be, and I would say that almost anyone, even if in CMG you're interested in something later on in life, you don't know how the hell you're going to feel after 3, 4, 5 years of residency. You may feel like, what the heck was I thinking? I wanted to be a vascular surgeon. That was crazy. So I'm like a epilepsy person, right? But I mean, you don't know what you're going to want to do. You just want to be a good neurosurgeon, and then you can figure that out later. Like you have plenty of time to specialize and whatnot. So yeah, get into a good program. Like for example, this one, and then get a good training, and then you could sort out what you want to do after that.
Thank you so much.
I see there's one question in the chat here really quickly with the goal of the ambulatory and community rotation. So the ambulatory rotation is a GIM rotation. We use that, like a GIM being general internal medicine. The goal of that is so we can learn how to manage some of our own post-operative patients. Patients coming in and they discover they have hypertension, we can start a few agents without having to consult medicine. We learn some of the basics. We know how to initiate some early stages of management. That was what I tried to take away from that rotation. The community rotation is an opportunity for us to, one, see what community neurosurgery looks like, two, work in an environment where it's just one of us residents working with the community surgeons, learn from new staff, again, learn different ways of practicing, and get a greater exposure to a lot of spine surgery in the community too.
Yeah, and just to clarify, like the Windsor campus is like part of Schulich, like it's part of Western, like it's our faculty there, and like half the faculty down there were our own previous trainees. So yeah, it's a totally different practice, right? Working in a community hospital, right? So residents down there are gold because there's not too many of them. So like everyone, like you get a lot of attention when you go down to Windsor for sure.
Yeah, perfect.
Martin.
Hello. Thank you so much for this detailed overview of the program, and it's really exciting to hear from you. I was just curious, what's the volume like at a lot of the hospitals associated with Western, and how does it compare to, say, other centers around Canada? Is it very busy? Because I guess like as a resident, you want to be operating as much as possible to develop those skills. So I'm just curious about that.
I'm going to start with that one, Alex. So, volume is a double-edged sword. Okay. So, if the volume is very high, then typically surgeons are rushed. They're trying to squeeze in that third or fourth case of the day. And I think the teaching suffers. So, I think you have to be a little careful. I think the volume we have is average. It's not over the top. One of the things that, and I'll be very transparent, one of the things that I think is a bonus for students is that some schools are on a type of alternate payment plan, and some schools are what's called a fee for service. The surgeons are, okay? When surgeons are fee for service, they're really trying to cram in that last case. And I think that can, for the student, that can be, less than optimal because they'll get maybe a little less hands-on, and it's more about a speed thing. But speed in the wrong direction is still in the wrong direction. It's not the speed, it's velocity, and that's how we think about it. So if we are teaching you at with a reasonable caseload where you get to do a lot and you're not being rushed, then that's actually more valuable than having, us showing you numbers that's, 10% higher than school that's down the road. I don't think that's a good metric for you to consider. I think you should say, is the environment supportive of giving me an opportunity early on and later on when the cases are more complex? At what point will the consultant take over because they have to get the next case jammed in? And so, again, it's a double-edged sword, but I think we've struck the right balance.
Yeah, just to add to that, and I think it would be nice to hear Alex's opinion on how he thinks the volume is, right? But because I would say average is a good description. Like there's some places, there's some hospitals that are out of control, like totally out of control in terms of the volume, and it's like kind of a madhouse for the single resident who's on there. Okay, and there's some places that don't have enough of a certain kind of case. Like there's a wide range of things. Um, you know, our busiest service by far is University Hospital. That's where the most of the action takes place, and that's where we have 2-3 rooms a day. It's pretty busy. That's where most outside calls come from. That's where all the calls are generated from. And then the other service, like the Vic, where the trauma is and all that's a little lighter. That's kind of a slight infolded break for the residents when they're down at that site. It's peds and adult trauma, which isn't that busy. So I don't know. Alex can comment on his volume exposure, I guess.
Yeah. So speaking the last few months, I was at University Hospital and I recently went over to the Victoria Hospital. But I think it's been a great volume to learn with. Again, just like Dr. Duggal and Dr. Stevens said, the volume is at an appropriate pace where I'm able to be walked through more difficult parts of operations, and I don't feel like there's this pressure of why are you going too slow? We need to get through this case so I can get the next 6 cases out of the way before they close my rooms. And that's a very, very, very valuable thing because then in the future, as I further advance through training, it'll give me the leeway to be more comfortable moving through some difficult parts of cases, knowing that I've had that solid foundation, learning basic principles, and I've been able to do that in a very controlled and well-taught environment. At the pediatrics hospital as well, I think our volume is very, very good there, in that we do a full spectrum of pediatrics and including a lot of what, at least from what we see, is a very heavy part of pediatrics, and that's epilepsy. We do a lot of SEEG there, a lot of VNS there, and we have the opportunity to be taught how to do those by the consultants, which again, very valuable. And with the cranial trauma that comes in, it keeps our skills on the adult patients sharp while we're there too.
Categorically, you are going to be able to do anything when you finish this program. Ottawa, Alan Shalil, he can do anything. Burnett Johnson, he can do anything. I mean, the residents that are, some of the people that have gone on to our other, Eve Starveld in Calgary, he can do anything. Bill Wong in McMaster, he can do anything. You finish this program, you can do anything, and you can do it, and you'll do it well.
Perfect. Thank you so much for that unique perspective on volume. I appreciate that. This is things I've heard, so I appreciate that advice too.
Perfect. Thank you very much, Dr. Stephen, Dr. Duggal, Alex, for joining in today. It was a pleasure having you guys, and thank you for the amazing discussions and the perspectives on neurosurgery. We look forward to hosting you next year as well.
I'd like to thank everyone for attending this evening, and we hope to see you. If we haven't come through London, please consider us for an elective. We'd love to host you and to see you, to show you what we have. Take care, everybody. Bye-bye.
Thank you so much. Perfect. So next up we have Dr. Fournier-Gosselin from University of Montreal. This is the second time that we're hosting Dr. Fournier-Gosselin. It's a pleasure to have her with us. Donc, prochainement, on va avoir Dr. Fournier-Gosselin de l'Université de Montréal qui va nous donner la présentation en français, vu que l'Université de Montréal, c'est un programme en français. Donc, ceci étant dit, allez-y, Dr. Fournier-Gosselin, c'est bien de vous avoir parmi nous. Vous pouvez
Oui,
partager
bonjour,
votre écran.
Fabod. Merci pour la belle introduction. Merci aux gens là, qui sont avec nous. Évidemment, là, c'est normal là, que l'audience soit un peu plus réduite. Je vais d'abord essayer de voir pour partager mon écran là, si tout est possible. Attendez un petit peu. Share. Présentation. Celle-là. Ça devrait. Share. Oui. Je vais essayer de mettre ça en diaporama. Bon. Là, est-ce que vous l'avez en diaporama?
Oui, on voit bien là, à l'écran.
En diaporama, parfait. Alors, je vais commencer tout de suite. Donc, oui, merci. En fait, c'est la deuxième fois parce que cette année 2026, nous aurons un poste en neurochirurgie à l'Université de Montréal. Je suis la directrice du programme. Vous avez ici mes coordonnées là, si vous avez des questions additionnelles ou d'autres discussions là, qui pourraient s'étendre en dehors de cette présentation-là. D'entrée de jeu, je vous montre un peu les endroits où se font le principal de l'enseignement. D'abord, le CHUM, l'hôpital universitaire là, de l'Université de Montréal, qui est l'endroit principal de formation. Mais les étudiants vont être amenés aussi, les résidents, à faire des stages à l'hôpital Sacré-Cœur de Montréal, le lieu où il y a entre autres la traumatologie, mais il se fait évidemment beaucoup de neurochirurgie là, de plus en plus de base du crâne. Il y a beaucoup de rachis traumatiques. L'hôpital Sainte-Justine, c'est l'hôpital pédiatrique où les résidents vont aller faire des rotations lorsqu'ils sont un peu plus avancés. Et on a la possibilité d'avoir des stages en communauté, entre autres aller avec l'hôpital de Trois-Rivières. Là. Et bon, les personnes principales là, qui nous soutiennent à la direction de programme, c'est Madame Jules. Et puis, il y a différentes adjointes hospitalières dans chacun des hôpitaux là, qui sont là pour accueillir les résidents. Donc, depuis 2020, déjà, on est avec le programme là, en CPC. Donc, ça veut dire que maintenant, tous nos résidents font partie de ce nouvel cheminement. Vous n'êtes pas la première fois que vous écoutez les présentations, puis j'ai pas eu l'occasion de me joindre plus tôt, mais on se rappelle que à l'entrée à la résidence, il y a une période de progression vers la discipline. On va acquérir les fondements de la discipline. On va finalement être dans la période maîtrise de la discipline où on va passer l'examen. Et on revient de l'examen, on fait la transition, puis un dernier examen oral avant de pouvoir euh, vraiment graduer. Et le but, c'est vraiment de faire de vous des experts avec toutes les belles pétales CanMeds, là, donc de pouvoir avoir des stages qui vont vous amener à développer là, vos talents. La neurochirurgie de l'Université de Montréal, elle est complète là, en termes de sous-spécialité d'exposition, tant dans la neuro-oncologie, la base du crâne, la vasculaire, que ce soit endovasculaire ou ouvert, le rachis, minimalement évasif, ouvert, traumatique, dégénératif, oncologique, la traumato, la pédiatrie, la neurochirurgie fonctionnelle qui est ma spécialité, la neurochirurgie de l'épilepsie et les nerfs périphériques avec l'aide de collègues neurochirurgiens qu'on va soit aller chercher à Québec ou avec euh, les, euh, les plasticiens là, de l'Université de Montréal. Donc, durant les stages, évidemment, vous allez pas seulement exposé à de la neurochirurgie en tant que telle, mais tout ce qui est nécessaire d'aller chercher en termes de soins intensifs, de chirurgie, de trauma, d'ORL, d'infectiologie, les stages de neurologie qu'on essaie de développer de plus en plus en lien pour qu'ils soient pertinents avec la pratique future. Donc, d'aller chercher de la neuro-ophtalmo, des troubles du mouvement, de l'épilepsie, de la neuro-onco. Évidemment, il y a des stages dédiés en radiologie et en pathologie. Donc, on a un hôpital quand même avec, je dirais, de la haute technologie. On n'est pas rendu à brancher directement les électrodes comme ça dans le cerveau, mais on a accès à bien des technologies. Je pense entre autres au lit laser, là, mes collègues, là, pour traiter des foyers épileptiques ou des petites tumeurs profondes, inaccessibles, ben, difficilement accessibles. Bon, moi, je m'occupe de tout ce qui est la DBS. On développe également la DBS en épilepsie avec mon collègue. On a accès évidemment à tout ce qui est monitoring, l'ICOX, les IRM, l'IRM intraopératoire en pédiatrie, tout ce qui est endoscopie ventriculaire, tout ce qui est endovasculaire, avec des collègues, des liens, des neurochirurgiens, mais neurochirurgiens qui sont hybrides, là, qui font à la fois la vasculaire ouverte et endo, mais aussi avec les collègues de radio. Tout ce qui est microscopie avec fluorescence, évidemment, on utilise ces nouvelles données-là que vous avez ici là, dans le bas de la photo. Logiciel de neuronavigation. De plus en plus de chirurgie éveillée. Ils sont en train de finir un cas ce soir, là, une grosse chirurgie éveillée d'une énorme tumeur de bas grade. Le MIS pour la, le rachis. Donc, je vais juste vous dire que on a les technologies là, avancées. On a de la place aussi, c'est important d'avoir des mois de stage réservés pour la recherche. On a un minimum de 6 mois de stage réservés dans le curriculum pour la recherche clinique et ou fondamentale. Beaucoup de nos résidents, s'ils sont déjà avec une maîtrise quand ils arrivent, vont soit compléter ces mois-là pour aller chercher autre chose, des fois vont aller vers un PhD, mais s'ils n'ont pas de recherche préalable, ben, ils vont simplement faire leur mois de recherche avec des beaux projets à l'intérieur, avec des liens, soit avec les neurochirurgiens évidemment, mais aussi avec les équipes, là, entre autres de génie à Polytechnique par exemple, ou avec les neurosciences. Il y a différentes chaires et fondations qui peuvent aussi être sollicitées pour aider, pour payer des bourses, par exemple. Le directeur de la recherche, c'est Dr. Alex Veil, là, qui est très impliqué en recherche, là, comme certains le savent parmi vous, là. Nous avons des activités évidemment académiques. Elles sont sur une rotation de 2 ans là, pour passer à travers tout le cursus là, de la neurochirurgie. Donc, on a une demi-journée académique qui est le vendredi matin. Euh, Comme nous sommes des petits programmes, nous sommes alliés avec nos collègues de Sherbrooke et de Laval pour avoir un cours le matin, 1 heure conjointe sur les éléments de base pour aller chercher les meilleurs présentateurs dans le domaine. Et après, il y a 2 heures qui sont plus sous forme de club de lecture, qui sont entre résidents avec patron. On a aussi un cours de neuroanatomie qui se donne le mercredi avec Dr. Bojanowski, des ateliers de microchirurgie qui se rajoutent, de simulation. Évidemment, on prépare les examens les résidents à leurs examens finaux avec des pratiques d'examen, où on fait venir tout le monde là, du milieu francophone et même de McGill, là, du côté anglophone, pour pratiquer les Québécois aller aux examens du collège. On a aussi les activités mieux-être, je vais vous en parler un petit peu plus tard, là, auxquelles on fait un peu de team building. Donc, quelles sont les forces de notre milieu? Ben, on croit sincèrement que d'avoir une participation précoce et variée aux chirurgies, c'est le nerf de la guerre, là. On veut d'abord vous former en vous des neurochirurgiens, donc il faut être en soldat. Pas juste regarder, là, il faut participer, il faut être impliqué à différents niveaux. Et pour que ça se passe bien, mais ça prend une interaction qui est collégiale entre les résidents et les patrons. Puis pour ceux qui auront fait des stages chez nous, là, je pense que c'est des choses qui ressortent, là, comment on peut être, on est impliqué, on va être prêt, on veut que les choses, que les résidents soient bien encadrés. Nous avons des évaluations de 360 degrés, c'est-à-dire que lorsqu'on rend l'évaluation, on a parlé à tout le monde, on a parlé avec les infirmières, on a parlé avec les plus jeunes, les plus juniors, les plus seniors, pour vraiment s'assurer que, on a une évaluation qui rende compte de plusieurs aspects. On a évidemment aussi un système de coaching, mentorat. Présentement, chaque résident se choisit un mentor qui peut aussi varier dans le décours de la résidence, mais quelqu'un qui va l'épauler pour différents aspects, choix de carrière, orientation, Je donne un exemple, là, par exemple, moi j'ai été le mentor pour un de mes résidents qui avait un intérêt en fonctionnel, qui est maintenant rendu à Lausanne. Donc, l'accompagnement que je pouvais lui donner de coaching, il avait peut-être pas besoin de tant de choses. Il faisait beaucoup de choses par lui-même, mais des fois, d'avoir un petit ben, ça peut être aidant. Puis, il semblait avoir apprécié ce mentoring-là. On respecte la convention pour de la collective de la FM, des résidents du Québec. Ça, c'est en termes de nombre de gardes. Là, on est inflexible là-dessus. C'est déjà assez exigeant, là, la résidence. Là, il faut que les gens aillent se reposer, puis on veut qu'ils soient aptes à faire des chirurgies puis des actes importants en étant reposés. Mais c'est sûr que c'est exigeant, mais on respecte le nombre de gardes et des vacances et tout ça là, qui est selon la Convention. On favorise les gens à participer à des congrès, évidemment, là, nationaux. La NCQ s'en vient là, très prochainement. Il y a des chances que je vous vois là-bas. Viendrez me voir, viendrez me dire un petit bonjour. Je vais y être. Donc, les congrès provinciaux, mais évidemment aussi les congrès internationaux pour présenter le fruit de leurs travaux. Donc, je parlais du mentorat, donc pour la formation complémentaire, planification de carrière, là, c'est les éléments. Donc, notre programme est petit pour différentes raisons. C'est pas on n'aurait pas les capacités d'avoir plus de monde. Effectivement, ça roule à l'Université de Montréal. On a beaucoup on a un bon volume de cas et tout ça. Mais c'est des questions d'enjeux ministériels. Là, on est limité encore à un résident aux 2 ans, ce qui fait que ben, sur 6 ans, on a un résident par 2 ans, comme vous voyez. Donc, 6 divisé par 2 égale 3. Laurence qui est maintenant R2, Félix R4, Tristan qui termine cette année comme R6. Nous allons donc accueillir un prochain résident ou résidente l'année prochaine. On est très excités d'avoir du nouveau monde. Voilà. On a dans la balance beaucoup de fellows avec nous parce que ça demeure quand même beaucoup de travail et on croit qu'on a un potentiel de former et de rayonner là, avec des gens qui viennent un peu partout. Donc, on a ici, par exemple, Dr Michri qui vient du Maroc, Dr Kaozi qui vient du Brésil, Dr Gemel qui vient de Tunisie, Morgane de France, on a Flavie de France, Claudia qui vient de Colombie. Les deux d'en bas sont en pédiatrie et en traumato, donc nos hôpitaux ont différents là, fellows là, qui sont là. Puis il y a une belle collaboration avec nos résidents. Notre façon de fonctionner, c'est toujours d'abord le résident va au maximum de ce qu'il peut faire. Puis après ça, le fellow va pouvoir embarquer. Puis souvent, il y a tellement de salles de toute façon que c'est difficile et les cas sont longs. Alors, le relais est juste bien apprécié. Actuellement, on s'assure que ça se passe bien. Puis ce que j'ai comme retour, c'est que les gens apprécient là, l'interaction là, entre les deux. Là. Et surtout l'aide qui peut être apportée, ça, c'est pas négligeable là, pour tout le travail clinique, la tournée des patients, le suivi, les gardes, etc. Donc, ici des exemples un peu de notre façon d'interagir par opératoire, donc d'avoir le résident impliqué, un coaching un pour un, ici on est brossé, mais bien des fois, quand ils sont plus âgés, ben on n'est pas loin, puis on regarde, puis on veut aller laisser le résident au maximum. Alors là, c'est un bel exemple où vous avez ici Docteur Labidi, là, bon, qui a les bras croisés, puis qui regarde le résident faire l'opération. Mais il regarde tout, il suit ça pas à pas, mais millimètre par millimètre pour cette résection-là. Puis là, ici, on a quelques petites personnes qui regardaient, là, c'est avec notre microscope, là, je veux dire le 3D, là, avec les lunettes là, pour voir la profondeur. Donc, ici, des exemples de résidents qui sont en présentation, en congrès. Ici, ce bébé-là, ben, c'est le bébé de Dr. Rasco, qui est notre résident qui est maintenant en fellow et qui revient très prochainement. Bon, bref, des petites photos un peu comme ça. Présentation lors des congrès, évidemment on vous inciterait à y participer. Puis bien d'entre vous, je sais que vous êtes déjà d'excellents orateurs parce que je vous ai vu déjà dans les conférences. Activité mieux-être, escalade. Alors ici, ben, c'est pour montrer que ben, notre gang est plutôt sportive là, la plupart du temps. Et qu'ici, ben, vous avez la patronne là, qui essaie là, avec son espèce d'escalier là, de suivre la gang. Là. Puis moi, ça m'a pris tout mon petit change pour monter en haut, alors que les autres, c'était des vrais Spider-Man, là. Bon, bref, on essaie de suivre la gang, mais c'est très, très drôle, ces activités-là. On a eu aussi une activité de jeu d'évasion où on s'est bien amusé, là, parce qu'il y avait une partie de la gang, là, qui avait été vraiment très rapide, puis l'autre, c'était épouvantable comment ça sortait pas. Alors bon, des petites choses comme ça qui sont agréables, là, de se voir dans d'autres conditions. Réunion académique. Donc, ici, un exemple pour la réunion là, de neuroanatomie là, du matin, le docteur Obaye, docteur Bayanovski là, qui sont ici présents. Fait que cette fameuse réunion anatomique, je me suis permis une petite pointe là, parce que c'est vraiment une étude très poussée de l'anatomie, là. Puis ça, c'est une photo à l'époque là, où on avait, vous reconnaîtrez le docteur Champagne qui maintenant travaille à Québec. Ici, il y a un petit trou, ben là, un moyen trou, puis là, un gros trou, là. On est très, très poussé dans notre anatomie, là. Quand on sort de là, on connaît tout. Bon, écoutez, je me permets un peu d'humour, là. On n'est pas si nombreux que ça à être en ligne, là. Puis c'est vendredi soir, jour d'Halloween, alors... Donc ici, d'autres images là, de l'équipe en congrès ou dans différentes occasions. Donc, si on parle un petit peu plus du CHUM, Centre hospitalier universitaire en plein centre-ville de Montréal, on est à 2 pas du quartier chinois, à 2 pas du Vieux-Port, du Vieux-Montréal, Vieux-Port. Les centres, le métro à proximité, c'est vraiment, on est downtown, là, vraiment, c'est vraiment bien. Notre équipe, alors, je vous les présente. Docteur Alain Boutillier qui fait l'épilepsie, docteur Obaïd d'épilepsie, c'est notre officiellement premier clinicien-chercheur là, qui a donc un demi-temps recherche, demi-temps chirurgie, mais son demi-temps chirurgie, je pense qu'il s'appelle plus que demi, là, je sais pas, il doit avoir plus d'heures là, que dans son horaire que nous autres. Moi, je fais la fonctionnelle, la douleur chronique. Docteur Jab qui est à la fois en endovasculaire et en vasculaire ouvert. Docteur Chalat qui fait le vasculaire ouvert. Docteur Bajanowski, vasculaire ouvert, base du crâne. Docteur Genari qui vient de se joindre à l'équipe, qui est en rachis, avec Docteur Chédid, rachis également, et Docteur You. Et Docteur Labidi là, qui fait toute la base du crâne là, complexe et tout ce que je suis pas capable de faire, là. Et nous avons Dr Mounjan qui va bientôt prendre sa retraite, là. C'est annoncé pour le début de l'année prochaine et Dr Esco va prendre le relais. Donc, ça, c'est pour la neuro-oncologie. Donc, Dr Esco arrive là, en janvier. À Sacré-Cœur, donc vous voyez le gros hôpital qui est déjà en rénovation, donc cette photo-là est probablement même plus bonne. Notre centre de trauma pour le côté là, francophone là, à Montréal, mais qui se fait aussi beaucoup de neurochirurgie générale, beaucoup de rachis, puis de plus en plus de neurochirurgie là, assez olée de base du crâne. Docteur Laroche, qui est aussi le président du comité de compétences. Il a été le directeur de programme pendant les années qui m'ont précédé. Docteur Lavigne, c'est lui qui fait là, les chirurgies là, de base du crâne, amener l'expertise vers Sacré-Cœur. Docteur Dragos-Katana qui s'est joint à l'équipe dernièrement. Docteur Giroux qui est encore là pour quelques, je sais pas quoi, pour quelques années, qui a une vaste expérience. Docteur Quer qui est le neurochirurgien, mais du côté Rachid, donc beaucoup avec l'équipe là, d'orthopédie. Puis à Sainte-Justine, là, donc un hôpital aussi là, qui s'est vraiment là, développé. Là, tout a été une grosse portion de nouvelles là, dans les dernières années. 3 neurochirurgiens, Dr. Veil, qui est maintenant avec le clinicien chercheur, là, gros programme de recherche, fait de plus en plus d'épilepsie. Et Dr. Venn, qui est là, à la fois le euh, neurochirurgien là-bas, mais aussi le directeur de la chirurgie. Ah, ma petite famille arrive de l'Halloween. Ça va, les enfants? Vous avez ramassé des bonbons? Vous n'êtes pas trop mouillé? Bon, excusez, petite interruption d'Halloween, là. Donc, voilà, vie familiale. Vendredi soir, 9h. Donc, Dr. Ben, qui est aussi, comme je disais, le chef du département de chirurgie. Dr. Westwick, qui a complété là, son fellowship un petit peu plus tard là, pour aller joindre l'équipe, il fait beaucoup l'oncologie. Il est aussi beaucoup impliqué en pédagogie. Et à Trois-Rivières, ben, on a des neurochirurgiens, là, Dr Pelletier, Gendron, Claude Édouard et Jonathan Chénier, qui ont une pratique principalement plus générale, bien qu'ils aient des backgrounds de fellowship assez impressionnants, Dr Châtillon et Chénier. Puis, ils sont très impliqués aussi au niveau de la NCQ et tout ça. Vous pouvez voir? Je sais pas si c'est bon de voir. Alors, Émile, qui était déguisé en pharaon, là.
Mais
j'ai-
je suis déguisée.
Ouais, c'est ça. Là, veux-tu te montrer ton chapeau? Tant qu'à faire. Pas juste le maquillage, là. Alors, ben, Montréal. Pourquoi choisir Montréal? Si je vous ai pas convaincu, ben, c'est parce que c'est cool, là. On mange bien, il y a bien des activités, on peut faire bien du sport, on peut aller encourager nos Canadiens qui perdent. Non, c'est une blague. Ils gagnent, là? Oui, ils sont meilleurs. Bon, moi, je suis tellement pas là-dedans, là. On peut bien manger les bagels, ça dépend de ce que vous voulez, de la poutine, whatever, là, nos spécialités locales, fine gastronomie. Puis, ben, c'est ça. Donc, le processus d'admission, comme je vous expliquais, un poste aux 2 ans, le prochain poste en 2026. Je pense que là, j'ai pas le choix de vous montrer les deux enfants. Alors, Émile, OK, voilà, Justine qui est contente de ses bonbons.
Ouais.
Merci les enfants, à tantôt. Bon. Alors, 2 postes par année au Québec, hein. Il y a l'alternance entre l'Université de Montréal-Laval puis l'Université de Sherbrooke-McGill. On suit le processus du CaRMS standard, comité d'admission. Donc, les membres du comité d'admission vont être présents. Donc, directeur de programme et les neurochirurgiennes de la division qui sont dans le comité de programme. Puis, évidemment, on a tous les résidents du programme. Ils sont 3. Alors, ils viennent tous au comité d'admission. Je pense que je vais mettre des petites. Je vais juste mettre mes écouteurs. Les enfants. Ça va pas long. Les enfants. Des petites secondes. Je pense que ça va être moins bruyant. Euh, donc, excusez-moi, je voulais pas aller trop vite là-dessus. Le comité d'admission, c'est ça. Donc, ensuite, c'est des entrevues qui sont individuelles. Le format est encore virtuel cette année. C'est le choix du CaRMS, donc on va évidemment respecter ça. Les gens nous demandent toujours un peu c'est quoi vos grilles ou vos façons d'évaluer. Donc, on a une grille assez standard où on évalue de façon pondérée, votre formation académique. Vos évaluations de stage ont beaucoup d'importance. Donc, on lit vraiment tous les stages où vous avez passé pour voir. Parce que maintenant, avec les notes, c'est tout pass or fail, hein, fait que c'est difficile de voir comment discriminer là-dedans. Donc, des stages où vous avez été apprécié, tout ça, donc on ressort ça. Votre lettre de présentation qu'on espère pas être passée dans le chat GPT, là, qu'elle soit réelle, là, qu'elle soit de votre de votre vécu à vous, là, pas de ce que ChatGPT pense, là. Votre lettre de motivation, là, pourquoi vous voulez faire la neurochir. On regarde les lettres de référence. C'est sûr que c'est rare que ça va être très mauvais, mais bon, ça peut nous donner des indices. On aime vraiment avoir au moins un stage en neurochirurgie, là. C'est comme le minimum là, pour pouvoir dire je veux faire de la neurochir plus tard, là. On regarde tout. Vos expériences antérieures, avez-vous fait du bénévolat? Avez-vous travaillé? Quels sont vos hobbies? Dans quoi vous vous êtes impliqué? Comment vous avez été leader? Comment vous avez été impliqué dans ci, ça? Tout ça pour nous a de la valeur. Quelqu'un qui a fait des années de musique, des années de sport ou d'art ou de quoi que ce soit d'implication, on peut lire à travers ça, ben, quel type de personnalité cette personne-là. Est-ce que ça peut fitter avec la neurochirurgie? Puis est-ce que c'est quelqu'un avec qui on va avoir le goût de travailler pendant les 6 prochaines années et pour le reste de notre vie comme collègue. On regarde aussi vos expériences de recherche, une pondération pour ça. C'est sûr qu'on ne s'attend pas à ce que les gens aient des PhD puis publiés comme des fous, là. On cherche d'abord des gens qui vont faire de la neurochirurgie, mais de plus en plus, l'aspect recherche, évidemment, montre un signe d'engagement et tout ça, etc. Ben, c'est parce qu'on a toujours une question, à un moment donné, un peu niaiseuse qui sort là-dedans, là. On est à Montréal. Fait que, tu sais, Docteur Laroche a laissé son empreinte aussi je pense que c'est une façon un petit peu de décontracter l'affaire, là. Tout le monde travaille fort, mais l'humour nous aide à passer à travers bien des éléments. Vous êtes au courant des grandes circonstances actuelles, super le fun en médecine qui se passe au Québec. Fait que je pense que j'ai vu aussi récemment que même les étudiants, vous vous êtes mobilisés pour faire un mandat de greffe. Je trouve que c'est wow, là, c'est quelque chose déjà que les étudiants ont beaucoup été touché jusqu'à maintenant par les mesures. En tout cas, je le passe, je le glisse au passage, là. Mais on est tous dans la même, le même combat, la même réflexion, puis on veut donner des soins de qualité, puis je pense que ça, il n'y a personne qui va nous enlever ça, là. Fait que voilà, je ne sais pas si vous aviez des petites questions pour moi. Je vais arrêter le partage d'écran. Puis, ben, c'est ça, je suis ouverte à répondre. Je sais que vous avez déjà eu beaucoup de, tu sais, j'écoute un peu le genre de questions qui allaient dans les autres universités. Beaucoup d'entre vous ont déjà fait des stages chez nous ou pas. Donc, vraiment, toute question est bonne. J'essaierai d'y répondre au mieux.
Parfait. Merci beaucoup, Dr. Fournier-Gosselin, pour la présentation. C'était vraiment le fun.
Bon, ça fait un
Ouais,
peu plus relax, là. Je sais que les autres,
c'est ça. Parfait. Merci. Donc, si vous avez des questions comme les anciennes présentations, vous pouvez juste unmute et allez-y. Alors, Daven, vas-y.
Bonjour, Dr. Fournier-Gosselin. Merci beaucoup pour la présentation de ce soir. Vous avez présenté tantôt là, le 6 mois de recherche qui était nécessaire par le Collège des médecins, puis le Collège royal. Si jamais, on a des études graduées, puis qu'on décide qu'on veut plutôt poursuivre un fellowship plus clinique, là, sans nécessairement faire un PhD, est-ce que c'est possible qu'on peut intégrer ça dans le parcours?
Ben, c'est ça. La recherche, c'est 6 mois où vous avez l'opportunité de faire avancer, de développer, faire avancer, également compléter un ou des projets de recherche. Qu'ils soient dans un projet de maîtrise, PhD, whatever, ou juste recherche standard sans être relié à des études graduées. On veut que les gens aient quand même une exposition minimale à la recherche. Et ce 6 mois-là n'est pas nécessairement d'un bloc. J'ai beaucoup de résidents qui disent, ben écoute, je commencerai tel projet, je ferai ma revue de littérature, blablabla, bla. Après ça, j'analyserai mes données, mais peut-être un petit peu plus tard. Puis après ça, j'aimerais ça avoir du temps pour rédiger ou telle chose. On s'adapte vraiment selon ce que les gens ont. D'autres arrivent avec une maîtrise, puis là, ils ont besoin de temps pour rédiger. Ben, ça va vers ça. Fait que vous comprenez un peu l'idée, c'est on veut qu'il y ait des projets de recherche là, qui soient faits. Puis l'idéal, souvent les résidents vont avoir plus qu'un projet de toute façon dans la résidence à laquelle ils vont pouvoir être exposés. Mais il y a du temps protégé pour ça. Parce que si tu veux que ça avance ta recherche, tu ne peux pas être en même temps en train de travailler puis faire ça le soir, la fin de semaine, là. Il faut vraiment qu'il y ait des périodes dédiées, là.
Merci beaucoup. Donc, c'est difficilement le temps qu'on peut prendre pour faire un fellowship clinique intégré, par exemple.
Quand tu dis un fellowship clinique, ce serait quoi, par
Ce
exemple?
serait par exemple d'aller faire un 6 mois de spécialisation en technique particulière X d'une certaine procédure dans un autre hôpital, dans un autre centre.
Oui, c'est ça. Les mois de recherche ne sont pas échangeables pour autre chose. Par contre, on a du temps il y a beaucoup de mois de neurochirurgie eux-mêmes. Puis, on regarde un peu avec les résidents. Il y en a qui me disent, écoute, j'aimerais ça prendre ce temps-là parce qu'il y a des stages à option. Fait que peut-être que toi, ce que tu penses en fellowship, ce serait comme des stages d'option où tu pourrais aller compléter ou faire davantage de telles choses. On est un programme, je dirais, assez flexible. J'ai eu des résidents qui ont dit, moi, je veux faire de la neuro-onco. Et puis là, ben, ils ont dit, ben, je voudrais aller faire de la neuro-onco ailleurs aussi. Donc, on a organisé un mois, par exemple, à Québec avec Dr Michaud, là, qui faisait de la chirurgie réveillée. D'autres m'ont dit, ben, j'aimerais ça aller faire de la fonctionnelle ailleurs aussi. Puis là-dedans, ce que je comprends souvent, c'est les gens veulent se faire connaître dans différents milieux. Puis on comprend la situation. Fait qu'il n'y a rien de tel que d'aller faire des stages, ne serait-ce qu'un mois ou 2 mois ailleurs, dans un domaine qu'on peut penser être éventuellement recruté. Fait que ça, c'est des choses qu'on regarde. Mais quand c'est plus là, tu sais, R 4, 5, 6, là, tu sais, des fois un petit peu plus tard dans la formation. Puis on y va un petit peu, puis il y a des stages qu'on a créés. Là, tu sais. On dit, OK, ben, on va créer, tu vas faire un mois là, puis ça va s'appeler comme ça. Puis au Québec, on se connaît tous, là, fait que c'est pas compliqué. Là. J'appelle les directeurs de programme à l'autre place, puis bon, j'ai un résident qui va aller chez vous, telle date. OK, fine. On va l'organiser le stage, puis on s'organise pour que les APC soient remplis, puis que des choses se fassent. Puis, ce qui arrive un petit peu plus vers la fin de la résidence, puis là, c'est nouveau avec la transition vers la pratique. Par exemple, là, j'ai Tristan qui, lui, va éventuellement aller travailler plus à Sacré-Cœur. Fait qu'on a organisé qu'il y a comme un 3 mois de stage dans son R6 où il est à Sacré-Cœur en train de faire ce qu'il va faire patron là-bas. Donc, vraiment de la transition vers la pratique. Si j'ai quelqu'un qui veut faire de la pédiatrie, je l'enverrai à Sainte-Justine faire d'autres mois de pédiatrie plus spécialisés, par exemple, ou ailleurs. Quelqu'un qui veut faire telle chose. Donc, l'idée, c'est de dire, aller faire des mois qui ressemblent un peu comme un pré-fellowship, là, hein, si on veut, dans ce que tu vas faire comme pratique plus tard, ou ce qui se rapproche le plus de ta pratique. Quelqu'un qui va vouloir aller plus en communautaire, ben, je l'enverrai à Trois-Rivières, par exemple. Un exemple comme ça, ou ailleurs, là. Le plus proche de ta pratique, pour que le step vers la pratique soit un petit peu amoindri, là. C'est un exemple de vers quoi le Collège Royal tend à nous amener, puis je trouve que c'est super logique. Fait que ça répond
D'accord,
peut-être
merci
plus à
beaucoup.
ton côté fellowship clinique, là.
Oui, vraiment. Merci
Mm.
beaucoup.
Parfait. Est-ce qu'il y a d'autres questions Oui, Ali, vas-y. Brièvement, parce on va...
Salut, docteur Fournier-Gosselin. Question pour vous. C'est quoi l'importance que vous donnez pour les stages qu'on fait hors UDM, hors Québec? Est-ce qu'il y a une plus-value à ça pour vous?
Ce serait quel genre de stage, par
À
exemple,
l'externat.
à l'externat? Tous les stages sont regardés. Il n'y a pas nécessairement une plus-value. L'important, c'est de voir comment vous vous êtes comporté dans le stage, là, quel genre d'externe là, vous étiez là-dedans. Vous avez collaboré, vous avez travaillé, vous étiez bon avec les patients, blablabla, tu sais, tout ce qui est les éléments d'un bon clinicien, puis de voir des fois quels commentaires ressortent. On essaie de lire un peu avec ce qui nous est donné comme matière pour essayer de se faire une idée globale de et c'est pas compliqué. Si quelqu'un a toujours des bons stages, ben, tu dis ça doit être correct, là. Tu sais, si quelqu'un a toujours des stages un peu moyens, tu dis ouais, il y a peut-être quelque chose. Soit qu'il n'a pas été chanceux puis qu'il ne s'est pas fait évaluer partout, mais il finit par avoir des stages où il y a des gens qui t'ont bien vu, là. Fait que, tu sais, les bons étudiants, absolument, ben, c'est des stages un peu partout, ça ressort bien, là. Mm.
OK, merci beaucoup.
Tu sais, on les regarde tous, là, que ce soit la pédiatrie, la médecine interne. Nous, on va traiter des enfants, on va traiter des adultes. Le stage de gériatrie est important. On a des personnes âgées. Je veux dire, il n'y a pas un stage qui n'a pas une valeur, là. On va chercher chez vous tous les éléments qui ressortent, puis après ça, qui sont applicables à la population neurochirurgicale.
OK, ça fait du sens. Merci.
Est-ce qu'il y a d'autres questions? Parfait.
C'est correct? Ben, au plaisir de voir
Merci
s'il y en a
beaucoup.
qui viennent à la NCQ. Ça va être un plaisir de vous voir. Venez me saluer.
Absolument, oui. Merci beaucoup. Puis
Pas de souci.
merci à Justine
Et Émile, oui, oui, oui,
ouais,
pour leur
pour là.
apparition impromptue. C'est
C'est
ça,
bien le
c'est
fun.
ça être maman. Maman et
Parfait. Merci beaucoup,
neurochirurgienne.
Dr. Fournier-Gosselin.
Bonne fin de journée.
Au revoir.
Au revoir.
All right. Next up, we have Dr. Chow joining from University of Alberta. Um, Hi, Dr. Chow. Welcome to our program. I believe this is you've been joining us every year. It's good to see you. Good to be back. Good to have you among us. With that being said, the floor is yours. You can go right ahead.
Thanks for inviting me, Farhan. Yes, I've been here before, like ever since it started, I think 6 or 7 years ago. So I've been doing this every year, but this is probably my last year as I'm about to relinquish the program director responsibilities to one of my colleagues. Um, for us, the big thing coming up in 4 weeks is it's our turn at the University of Alberta to undergo accreditation, and it's a 7-year cycle. So it's a big deal for us, and it's coming around the corner. But I'll give you an overview of our program. Are you seeing that? I think I shared it there.
Yeah, we can see the slides, but it's not in presenter mode.
Go to the
Perfect. Yeah, we can see it. It's good.
Let me just minimize this. So I've had to update the slides over the years, and unfortunately, I haven't had to update this slide because it's been pretty flat. When I joined the division in Edmonton in 2004, I was the 10th neurosurgeon there, but now we've grown to 16, and we've kind of set a new plateau there for the last 4 or 5 years. Our faculty ranges across all subspecialties in neurosurgery. We have 3 pediatric neurosurgeons. We have 4 neurosurgeons that do skull base work. We have 5 neurosurgeons that do spine. We have 1 functional neurosurgeon and 1 epilepsy neurosurgeon. And I myself do vascular and endovascular as part of a group of 4. And we have 2 neurosurgeons that run the gamma knife unit. And one of the spine surgeons is also fellowship trained in peripheral nerve, which is not that common in Canadian training programs. I had to update my slides also because I have recent data for our accreditation with the Royal College. And in the past year, we did over 2,500 cases. So it's a high volume center. We cover all of sort of from the middle of central Alberta up north to the Northwest Territories and Nunavut, and then also emergencies come from northern BC to us as well. So in that catchment population of 2.5 to 3 million people, we do over, our main site is the University Hospital, and that's where we do most of our all of our cranial work. We do over 1,100 cases in the past year. We also have complex spine elective practice at the Royal Alex Hospital. So it's 2 main sites, 2 adult sites, where they did 500 plus cases last year. The Stollery is our children's hospital. It's a hospital within the bigger University Hospital complex. And they did 250 to 300 cases last year. We have a very busy endovascular practice with 3 neurosurgeons and 2 interventional neuroradiologists, and we did over 450 cases last year. The Leduc Hospital is a community hospital near the Edmonton International Airport. It's about 20-30-minute drive from the downtown. And that's where we do a fair amount of simple spine, degenerative spine operations there too. I just mentioned in the corner here that one of the changes in last 2.5 years, is that we've been doing some of our simple spine out at a chartered surgical facility, which is a new thing in Alberta. But unfortunately, our residents are not allowed to go there, at least not yet. Our division has state-of-the-art equipment, so we don't lack for funding in Alberta. We've had our intraoperative MRI for quite a while now, probably at least 10 to 15 years now. We have it's not new anymore, but it was 10 years ago, a new clinic building. We have one of the few gamma knife centers in Canada. And we've had that at least, I'd say 4 or 5 years. We have this behemoth here, which is a CT scanner built within an ambulance. It's their stroke ambulance that goes out to potential strokes to get their CT scan before they hit the emergency room to save time. We're in development of a brain center where all of our wards and ICUs and ORs are going to be centralized. The equipment is also, we have all the bells and whistles. We have an exoscope. We have 3 brand new Zeiss Knievel microscopes, which is top of the line. Our residency program's expected to be 6 years, but like every program in Canada, we're on CaMSIGN by Design, CBD. And in that 6 years, you would expect to do between 42 and 50 months of neurosurgery. The first year is surgical foundations with the other surgical specialties in a joint program, and that's also CBD. In that first year, you do 7 months of neurosurgery. In year 2, you do another 7 months of neurosurgery, but you also do 3 months of ICU, a month of diagnostic neuroradiology, and 2 months of neurology. In year 3, you do 9 months of clinical neurosurgery, but you also do 3 months of neuropathology and a month of, when I say a month, I mean 4 weeks. So it's 13 blocks in a year. So a block of interventional neuroradiology as well. In year 4 is our flex year. In that year, you can do research for a year. You can usually get for instance, a master's in epidemiology or MP. Takes 2 years, then we have funding opportunities to allow you a salary stream for that extra year. Or some people have even taken longer, 3 years, 4 years, even 5 years for a PhD. We're pretty flexible for research. The other thing that residents do that aren't interested in a research career would be clinical electives outside of Edmonton. We offer that. I think for this upcoming year, we actually have one of our residents in her PGY4 year, she's going to do an infolded radiosurgery fellowship, which is one of the few fellowships you can actually do within your before you finish your core neurosurgery training. In year 5, it's basically all neurosurgery, and in year 6 is our final year for our lead resident or residents. We currently have 8 residents. We fluctuated anywhere from 8 to 10 residents in my term as program director. We currently have 1 lead resident. Some years we have 2. I remember 1 year before I became program director, there was 3, so it kind of fluctuates over the years. We currently have 1 resident away on research, and in his PGY4 year. We are taking 2 CaRMS spots, and we have for the last 3 or 4 years. We used to only take 1, but midway through my term here, we've started taking 2 CaRMS spots, because ultimately what I see for this program is that we need a sort of a core nucleus of 10 to 12, ideally 11 or 12 residents on our service. So we can allow the flexibility for residents to travel out of Edmonton for their research or electives. We also take foreign sponsor trainees from the Gulf states. We currently have 1 from the United Arab Emirates in his PGY4 year, and we just accepted Saudi to start on July 1st. So we take those residents too. Our academic curriculum runs over 3 years. So in the 6 years of training, you'll see the cycle repeated twice. We do it by subspecialty. So half a year, it'll be on one subspecialty, and the second half will be on another subspecialty. So we cycle through trauma and peripheral nerve, vascular, oncology, peds, functional epilepsy, and spine. We have a written exam at the end of each block. We have an annual mock oral exam, OSCE format, and there's the national practice exam that was started by one of our own faculty, Dr. Finley, who's retiring this year. When he was chief examiner of the Royal College, he started it and has kept it running all these years. I think he's got somebody to volunteer to take over that, running that exam as he goes into retirement. Our academic curriculum runs on Friday mornings. That's our protected half day. Usually the first half hour of the morning is a resident lecture, which is run by the residents for the residents. And they cycle through topics in neuroanatomy, neurophysiology. Our 8 to 9 is when the whole division is, or not the whole division, but a lot of the division shows up for our case rounds. It's where we present interesting cases, and this is where we quiz the residents. From 9 to 10 is a combined neurology neuroscience grand rounds, and we're expected to present at that about 7 or 8 times a year. the neuroradiology rounds has only been going on for 2 or 3 years now. It's a 15-minute, very short kind of focused topic on a particular imaging um, aspect of that two of our neuroradiologists have taken upon themselves to teach our residents. And it's been well received. Our 10:30 to 12 is an hour and a half of didactic teaching from our blocks, usually from faculty or from invited faculty, like sometimes neurologists, oncologists, and pathologists talk at that. In addition to the Friday mornings, we also have an afternoon where we add some additional academic programming. Our version of morbidity and mortality rounds, M&M rounds, are our quality assurance rounds. So that runs once a month, run by our lead residents. We have a journal club every 2 months, cycling through the topics, usually out at a restaurant, sponsored by industry. And a couple of times a year, we have our research rounds, and we have a research director who's faculty, Dr. Sankar, who runs those and helps with finding projects and guiding our residents through their research. About 4 times a year, we have a sim lab through our SMRI facility. Picture there, Dr. Fox. He's one of our complex spine neurosurgeons, and he basically designs the curriculum for that. We have equipment. We have an older Zeiss microscope that we moved down there that we no longer use in the OR. We have for drills and instrumentation systems, microsurgical instruments, and we can do microanastomosis with, I recently bought brand new micro instruments, same ones that we would use for like ECIC bypass to be used down there. Research expectations from the residents, they're expected to produce 1 project a year, developed and helped through the research rounds. And the 4th year, as I mentioned, can be used for dedicated research. There's this clinician investigator program, which can give you an extra year of funding if you want to do 2 years of research. It's like an extra year of salary, essentially. So we have had residents extend it to 2 years. The most, as I mentioned, was 5 years for a PhD. Last month, we went to Kelowna for, I think, the 5th year now. The residents have always voted to go back there, and we go do our resident retreat for a weekend in September. In the April and May, in the springtime, we have a joint meeting with Calgary's training program. So we have our residents and their residents present, and then we have, between the Calgary and Edmonton faculty, our business meeting at the same time on the weekend. The CNSF this year, the Canadian meeting, is now back to Banff, as I think was 3 or 4 years ago, and that's in June. Residents are encouraged to present in national and international meetings as well. If your quality of research is good enough, we certainly can find the funding for you to help you defray the costs of travel. So as I mentioned, we have 1 resident right now away on research. And he is in Paris right now doing a master's in neuroscience, focusing on oncology. This will be helpful because he wants to do an oncology fellowship or a skull-based fellowship when he finishes our residency program. There are multiple other opportunities. Other residents have done 1 year of ClinEpi masters. Some have done a medical education masters as well. And final word about why Edmonton, because it is one of the more northerly cities and probably the most northerly one of all the Canadian training programs. Summers are really long and beautiful, lots of sunshine. And we have the largest urban green space with the beautiful river valley. I didn't know this, but we had one of the highest per capita concentration of golf courses in Edmonton. Of any Canadian city. Here's a picture in a river valley. It's actually a golf course, a public golf course. The mountains are not that far away. Where Jasper's 3.5-hour drive. We're not as close as Calgary is because they're like half an hour to Banff. We're a little further away at 4.5 hours. Other attractions in Edmonton, of course, we have certainly cultural things like symphony, the Edmonton Symphony, the theater. We have theater, we have opera, we have one of the biggest malls in the world, the West Edmonton Mall, if that's your thing. And of course, our Oilers have been to the Stanley Cup twice the last 2 years. Festival city. So we have a ton of festivals, not just in summer, but also in the winter. And almost every weekend there's something going on. And we have different areas that are busy and up and places where there are nice restaurants and shopping. White Avenue, 124th Street restaurants. We have very good restaurants for our size of city. Let's see. There is one more thing here. Yeah. Okay. And one last note is that for those who are applying for CaRMS this year, this presentation, I'll give a condensed version on November 19th on Wednesday. We have a virtual open house, and every year this has been very valuable to I hear from all the applicants because I'm not hanging around for this open house after I do my presentation. I usually sign off and I usually ask the residents how it went, and they're usually on with the applicants for an hour and a half, 2 hours after I sign off every year, just without any faculty present, no pressure, just you get to see how the residents interact with each other. And it really is like a family. You can see that they know each other and they socialize with each other outside of the workplace. And so if you have a chance and you're applying this year, I would recommend that you, if you have time, attend this Zoom session. And that's it. Questions?
Thank you very much, Dr. Chow, for the amazing talk and for joining us for the 5th year. You'll certainly be missed next year at the program. With that being said, if there's any questions, Deven already has a question. Go right ahead.
Hello, Dr. Chow. Thank you for this wonderful presentation. You mentioned quite a bit ground rounds and the learning opportunities for the residents. Is there any available anatomical lab where the residents can practice their surgical skills?
Cadavers are hard to come by. We were the site for the PGY1 boot camp for neurosurgery. Up until this year, it moved to Toronto, but for 3 years running, we were the site. And we utilized those cadavers, the cadaver heads, to run our own kind of 2-day cadaver lab with surgical approaches. We used them before the PGY1s got around to using them for the boot camp. So we take advantage of that. We do sometimes have cadavers that are used by the surgical foundations training, like ATLS training. And so sometimes we can use some of that, but they're very expensive and hard to get access to. So we don't have like a regular thing every year, but we do plan on like supplementing our current simulation lab, which essentially uses more cruder models than real actual cadavers for instance, microsurgery.
Thank you, Dr. Chow.
Sorry. I just had a quick question. Dr. Chow, you had mentioned earlier on that University of Alberta kind of in terms of the communities that they serve, they also serve like the territories. I was wondering, are there opportunities from like a resident's perspective to participate in community placements or rotations? And if there are, would that include the territories as well?
The reason why they send patients down here is there is no neurosurgical center up there. Basically, in Alberta, there are only two centers that do neurosurgery. It's Calgary and us. And there's nothing in a smaller town like Red Deer, Grand Prairie, Fort McMurray. They send all patients to us because they don't have the infrastructure for neurosurgical practice. What we started this year, though, is we recognize that some of our degenerative simple spine is being farmed out to this chartered surgical facility. And it's a private facility, and for financial reasons, I've tried to get our residents in there, but they won't allow it. So because of this reduction in the exposure to like simple microdiscectomy and laminectomy, I've created a community rotation, and we're actually utilizing BC's resources because they have a number of community sites. Our residents have done electives before in places like Victoria. And I've created a mandatory 2-month rotation PGY3 year. This is the first year that's happening. And our PGY3 is going to go to Victoria for 2 months.
That's really interesting. Thank you.
Hi, Dr. Chow. Thank you. Thank you for your presentation. So I was wondering, you mentioned there are several hospitals offering neurosurgery service. So I was wondering if your residents covering all of them, and if so, like what's your temporality, like how long in each of them? Thank you.
Our main site is the University Hospital, and 100% of the cranial work has moved there. It used to be we did some cranial at the Royal Alex Hospital, but we just did not have the house staff to cover that. Our residents do go over there, usually for 2 or 3 months in their second year, another couple of months in their third year, where they're the only resident there. They're not behind a more senior resident. So it's a really good experience, but it is a lot of complex spine. They operate every day of the week there. And you're the only resident there. So they're very busy. The Children's Hospital is a dedicated rotation 1 month in their first year, 1 month in their third year. And if there are a lot of senior residents, then sometimes you get to 1 or 2 months in their fifth or sixth year. But you cover the patients and you cover the pediatric emergency room because it's actually physically inside the university hospital. So it's hospital within the hospital. And so those are our 3 main sites. So the community sites, our residents go out there to do some simple spine in the Duke Hospital. And so the 3 main sites are the Children's Hospital, the University Hospital, and the Royal Alex Hospital.
Thank you.
And just a brief question that I found it interesting for the simulation lab. That's you said it's 4 times a year, and how long is that? Is it like a day that they spend in the lab doing different techniques, or is it more like a longer period?
Yeah, it's usually just 2 hours in the academic half day in the morning. Instead of a lecture for an hour and a half, and then we usually cancel the radiology for that. We have a good 2 hours to spend there.
And is it possible for residents to just drop by and, like just practice some microsurgical techniques, some different techniques that they want to do under the microscope, stuff like that, or whenever they want, or is that not like a possible thing?
We haven't had that in the past, simply because we do have to book time there because it's a shared facility, and basically all the surgical services use it. I think that if you're actually on service, you just don't have time. I mean, thinking about just going off to this lab, you're just so tired that you're so busy during the day. There's so much demand. It's a typical neurosurgical residency, right? It's like it's fine in theory to think that you could have time to practice, but you have so much on your plate. that you really don't have time when you're on service to be doing that. I don't think any program would have time. Like you have to be in a program where there's so many residents, you don't have anything to do that you would go there. But most programs, I think, across the country are universally busy, such that you couldn't even think of that, having time to be going off and doing this in the lab.
Awesome. I guess it's just the naive thoughts of a med student then.
Yeah, you'll find out soon enough when
Thank you.
start your residency.
Is there any other questions from the audience? All right, then perfect. That wraps up our day. Thank you very much, Dr. Chow, for joining us for the, I think, fifth or sixth consecutive year. It was a pleasure doing these events with you. And thank you again for taking time out of your day for coming in and giving this talk.
Thanks. Have a good night.
You too. Have a good night.